Hi everyone. I hope I'm audible and visible. If I'm audible and visible, can I see a thumbs up on the live chat, please? Good evening, everybody. So, welcome everyone to the 100 one-liner session in biochemistry. And before we start the session, hi, good evening, Sushma. So before I start the session, let me wish you all a very happy Pongal, happy Makara Sankranti, and happy Lori. And I'm more than happy. Thank you, Sushma. I'm more than happy to be sharing my Pongal evening with all of you because this would be a productive evening for each and every one of us. Reason being, you will get confidence in facing any one-liner that can be asked in biochemistry as well as in clinical biochemistry. Good evening, everybody. I'm so happy to see the enthusiastic bunch of students here. Yes. So for you to have an overview of this session, in this session, I will be covering MCQs. Thank you, all of you. Thank you, Arvind. Yes. Happy Shankranti. So for you to get an overview of this session, in this session, I have covered totally 7 divisions. And in the first division, we will be discussing about clinical biochemistry, one-liners related to clinical biochemistry. Then one-liners related to carbohydrates, lipids, proteins, genetics, vitamins, and miscellaneous topic, which means I have tried my best to cover the entire biochemistry one-liners in this session. So stay put with me till the end of the session. At the end, not just 100 one-liners, you would have learned a minimum of 500 facts today, right? So with that introduction, you don't have to make notes because the PDF, annotated PDF will be shared with you. Is that clear? Yeah. And all facts that I'm telling you are provided as tables in this PDF. So stay here, just watch the session, listen to every fact that I tell you, memorize all facts as and when we discuss. Okay. So that after the session, when you get the PDF, all that is expected out of you is to revise the facts that we are learning during the session. Okay. Yes. So thank you. So let's start with part 1, clinical biochemistry. Thanks all of you. Yeah. So this is the first question for you. The most accurate method for estimation of serum creatinine is. Let me give you a clue. Whenever the question is about accurate, okay, always choose enzymatic. So the most accurate method for estimation of serum creatinine is enzymatic method. Of course, we have Jaffe's method, kinetic Jaffe's method. So kinetic Jaffe's method is regularly used in a clinical biochemistry lab. But if the question is the most, yes, PDF will be shared. Okay. Thanks. Yes. So PDF will be shared with all facts. Okay. So just listen to the session. Don't waste your time and energy writing down notes. Listen to the session. Be mindful during the session. Memorize all facts. Okay. So what is the right answer for this question? The right answer for this question is enzymatic method. This means you need to know what are the methods that are used for estimating other common analytes as well. Right? So let's fill up this table. Glucose estimation. The most common method used for glucose estimation is glucose oxidase peroxidase method. Okay, thanks for your wishes. Happy Pongal. Yes. So glucose oxidase peroxidase method is used for glucose estimation. For urea estimation, it is GLDH method, glutamate dehydrogenase method. For creatinine, what did I tell you? For creatinine, it is Jaffe's. Actually, to be very specific, it is kinetic Jaffe's. But the most accurate method, just now I told you, is enzymatic method. Okay. And then for bilirubin. For bilirubin, it is Vandenberg reaction. The test is based on Vandenberg reaction for bilirubin estimation. Total protein, it is BCG method. For total protein, it is Biuret method. Okay, so the most commonly used method for total protein estimation is Biuret method. For albumin, it is BCG method. Electrolytes, previously this was asked, electrolyte estimation is done using ion selective electrodes, or it can also be called as potentiometry. So can you repeat this? For electrolyte estimation, it is either ion selective electrodes or it is potentiometry. HbA1c, I'm very sure all of you have come across this MCQ. which is the most commonly used method for HbA1c estimation? It is ion exchange chromatography. Right? What is it? It is ion exchange chromatography for HbA1c estimation. Good. So can we repeat this for glucose estimation? Look at this. Look at the slide that is shown to you here. For glucose estimation, glucose oxidase peroxidase method. For urea estimation, it is glutamate dehydrogenase method. For creatinine, it is kinetic Jaffe, which is the most common, but the most accurate would be enzymatic method. Bilirubin is estimated by Vandenberg's reaction. Total protein is Biuret method. Albumin, BCG method. So this repetition is for your benefit. Please repeat it whenever I repeat a fact. Okay. So albumin is BCG method. Thank you, Shivam. Electrolytes is by ion selective electrode or potentiometry. HbA1c is by ion exchange chromatography. To be very specific, it is cation exchange chromatography. Okay, so that's about this MCQ. All of you, what is the right answer? Accurate is always enzymatic method. The test that is used to detect a reducing substance in the given solution is. Can you all start answering this? What is the method that is used to detect reducing substance in a given solution? The answer would be Benedict's test. Right? Very good. Answer is choice C, Benedict's test. But let's learn about all urine tests. Right? All the tests that can be done in urine to find out abnormal constituents of urine. Excellent. Excellent. I'm happy that all of you are writing it the right answer. So now about abnormal constituents. Yes, reducing sugar. All of you tell me what is the test. Just now I told you it is Benedict's test. And in Benedict's test, what will be the positive result? In case it is positive, then you'll observe a color change from blue. Right? From blue, it becomes green, or it becomes yellow or orange or red. Right? Blue color Benedict solution becomes green or yellow or orange or red. That's Benedict's test. If that is positive, it means there is some reducing substance that is present in the urine. Okay. For ketone bodies, this is a favorite MCQ of INI-CET. So for ketone body, what is the test that is performed? It is Ruthira's test. And what will you observe in the case of Ruthira's test? You will observe a purple colored ring. Okay, Ruthira's test, it is purple colored ring. For protein, urinary screening test done to detect protein is sulfosalicylic acid test. All of you repeat it. What is the test? It is sulfosalicylic acid test. If that is positive, you see a white color precipitate. For heme, right? Heme is either present whenever there is hemoglobinuria or whenever there is hematuria. So in the presence of hematuria or hemoglobinuria, urine has heme. In that case, it answers benzidine test. B for B, blood benzidine test. Okay. And if benzidine test is positive, you see a dark green or black precipitate. Bile salts. What is a test done to detect bile salts, all of you? Hayes test. Do you all remember playing with the sulfur powder? Yeah, dropping sulfur powder into urine sample and seeing whether the sulfur powder sinks to the bottom or does it float on top. Right? That is Hayes test, otherwise called as sulfur test. And if urine has bile salts, right? If urine has bile salts, then the sulfur powder sinks to the bottom. Yeah, if sulfur powder sinks to the bottom, then it is positive. Positive meaning urine has bile salts. It means the person has got obstructive jaundice. Bile salts positivity meaning obstructive jaundice. Bile pigments, it is Fauchett's test. And if Fauchett's test is positive, what do you see? You see a dark blue or green precipitate on the filter paper. Okay. So simply heating the test tube is what test? Simply heating the test tube is heat coagulation test. SS, have you got the answer? Simply heating the test tube is heat coagulation test. If that is positive, it means the urine has albumin. Right? To detect albumin, it is heat coagulation test where you fill the tube with 3/4 of the urine sample and then you heat the topmost layer. Right? If you see a white precipitate, then it means albumin is present in the urine. That's called as heat coagulation test. That's a good question. Bile pigments is Fauchett's test, in which case you see a green precipitate on the filter paper. Got it? So that's about abnormal constituents, the test. Yes. After heating the topmost layer, you add 1% acetic acid. Right? When you add 1% acetic acid, if the precipitate becomes stronger, it means it is albumin. If the precipitate disappears, it means it is phosphate. So don't get too much into details. Nobody is going to get into the details of all these tests. All that is expected out of you is to know the names of the test, what would it mean when it is positive, right? That's more than enough. So can you repeat this? When reducing substance is present in the urine, what is the test? It's Benedict's test, wherein blue becomes green or yellow or orange or red. Please repeat it along with me. Keep the chat box active, please, because it's all about facts. And the only way to memorize all these facts is to repeat it. Okay, so ketone bodies, if it is positive, which test will be positive? Rothera's test will be positive, and you see a purple colored ring. Proteins, sulfosalicylic acid test, where you see white precipitate. If urine has blood, right? To be very specific, if urine has heme, then benzidine test will be positive, where you see a dark green or black precipitate. Bile salts, Hayes test will be positive, wherein sulfur powder sinks to the bottom. Bile pigments, Fauchett's test, wherein you will see a green or blue precipitate on the filter paper. So what is your inference? If urine has bile salts and bile pigments, it means it is which type of jaundice, all of you? Obstructive jaundice. Okay. Rothera's test negative for beta hydroxybutyric acid. Yes. And for that, if you want to find out if it's beta hydroxybutyric acid, you can add acid to the urine. Make the urinary pH acidic and then perform Rothera's test. Then it will be positive. Okay. So what is answer, all of you? Reducing substance in the given solution. What is the test? It is Benedict's test. The tube that is used for serum electrolyte estimation. All of you, did you see this MCQ in the latest INI-CET November 2024? Yes. What is answer for serum electrolyte estimation? Please don't get confused here. It is not green. Are you clear? It is not green. Because if it's a green tube, it means it has got heparin. What is heparin, all of you? Heparin is an anticoagulant. The moment you add anticoagulant, please listen to this. The moment you place an anticoagulant, what separates above is called as plasma. Are you clear? The moment you place an anticoagulant, what separates above is called as plasma. The question is not about plasma electrolyte estimation. What is the question about? The question is about serum electrolyte estimation. Let me tell you about ABG in a bit. Please listen to this first. Yeah, so serum electrolyte estimation, you should not use green. If you're using green tube, it means it has got heparin, that is plasma electrolyte estimation. Okay, so for serum electrolyte estimation, what is the right answer? Green is not for ABG. All of you, listen to this first. Green is not for ABG. I hope you have all collected blood sample for ABG estimation. Right? Did you collect blood sample for ABG estimation in a syringe or in a tube? Can I see answers here, please? You would have collected blood sample for ABG estimation in a syringe, not in a tube. So green tube is not for ABG estimation. Green tube has got heparin, and that is used whenever you need a stat biochemical analysis. What do you mean by stat biochemical analysis? A quicker analysis. Okay. For example, TROP-I. TROP-T estimation, TROP-I or TROP-T estimation. Can you collect blood sample in a red top tube, or can you collect a blood sample in an yellow top tube? Both red and yellow, they have clot activator. I will be telling you about all this. All of you listen to this. Red and yellow, what do they have? They have a clot activator, which will stimulate clotting, which means you have to wait for the clot to get stabilized, and only then you can estimate, which means the turnaround time will be longer when you're using either a red top tube or an yellow top tube. Okay, so if it is TROP-I estimation or TROP-T estimation, a biochemistry lab, you cannot wait for the clot to happen. That is when you use a green top tube. Okay, so green is not for ABG. Let me come back to what we were discussing. Serum electrolyte estimation, you have to use yellow top tube. First, let me show you all these tubes. Okay, so look at the images that I'm showing you here. This is yellow top tube, which has a cap of yellow color, lavender, green, and gray. Let's start with what is yellow. Do you see a gel in the bottom? All of you? Do you see a gel in the bottom? So what is yellow top tube? Yellow top tube has a gel and it has a clot activator spray, right? Gel and clot activator spray. So what does clot activator do? It activates clotting. After clotting, what separates above is called as what? Serum. So whenever you need serum estimation to be done, please listen to me. All biochemical investigations need a serum sample. In that case, you can collect blood sample in an yellow top tube with a clot activator. Okay, so when I say serum, it is used for renal function test, it is used for liver function test, it is used for electrolyte estimation, it is used for any enzyme assay, any hormone assay, anything that is done in biochemistry lab needs serum, for which you can use a gel and clot activated tube. Are you clear? Now, what is this lavender top tube? Lavender top tube has EDTA. It has either K2 EDTA or K3 EDTA. Now, can you use this K2 EDTA or K3 EDTA tube for serum electrolyte estimation? No. For two reasons. One is EDTA is an anticoagulant. If you place an anticoagulant, what separates above is called as plasma. One reason. The other reason is if you're going to use a blood sample that is collected in an EDTA tube for electrolyte estimation, what will happen to potassium values? Potassium values will be falsely elevated. What will happen to calcium values? Calcium values will be falsely low because EDTA chelates calcium. So don't ever use the blood sample that is collected in a lavender top tube with K2 or K3 EDTA for electrolyte estimation. So what will you use K2 or K3 EDTA tube for? Whenever you need a whole blood sample. Okay. In this case, you're allowing clot to happen. If you allow clot to happen, will you be able to mix it again? You cannot mix it again. So whenever you need a whole blood sample, there should be no clotting. So then after some time, you can mix it. You can introduce it into the machine, right? For example, complete blood count. Yeah. So what? Yes, peripheral smear, complete blood count. Very good. Excellent. So complete blood count needs individual cells to remain separately, right? For that, you add K2 EDTA or K3 EDTA. Not only for complete blood count, even for HbA1c estimation. Because for you to estimate HbA1c, you need intact RBCs. What will happen if you allow clot to happen? In the clot, all RBCs will be trapped. So you will not be able to get HbA1c out of RBCs. So whenever you don't want clot to happen, whenever you need a whole blood sample, for example, for complete blood count and for HbA1c estimation, or whenever labile parameters like parathormone, ACTH, or ammonia need to be estimated. Labile parameters in biochemistry include parathormone, ACTH, ammonia need to be estimated. Even in this case, you use a lavender top tube. Excellent. Shivam, you're right. Okay. So ESR, for ESR blood sample collection, Wintrobe is the method SS. Do you understand this? What about, I will tell you. You wait for some time, I'll explain everything. Okay, so ESR Wintrobe tube is finally used for estimating ESR. But to estimate ESR, you should collect blood sample, right? In which tube will you collect blood sample for ESR? It is ESR tube which has a black top. For ESR, it is black top tube which has got 3.8% sodium citrate. For ESR, it is black top tube which has 3.8% sodium citrate. Okay, let's discuss about that later. Now coming back to what we were discussing, that's about lavender top tube for complete blood count, HbA1c, for labile parameters like parathormone, ACTH and ammonia. Okay, now green top tube, I told you, has got heparin. When did I tell you you have to use a heparinized tube? Whenever a quicker analysis in biochemistry needs to be done. Usually you collect blood sample in either red top tube or an yellow top tube for biochemistry. Both red and yellow have clot activator spray, where you have to wait for the clot to happen and then you can estimate. That will increase the turnaround time. But if you want a quicker analysis to be done, please go for heparinized tube, in which case it is plasma analyte estimation. Okay, for example, TROP-I, TROP-T, or even electrolytes, but that's called as plasma electrolyte estimation. Now this is the gray top tube, G for G. Can you all tell me what does G for G mean? Gray top tube is for glucose estimation. Do you understand this? Gray top tube is for glucose estimation. What does it have? It has sodium fluoride and potassium oxalate. It has sodium fluoride and potassium oxalate because fluoride inhibits enolase of RBCs. Do you understand this? Fluoride inhibits enolase of RBCs. Okay. Now, can you exclude all choices? I'm going to straight away exclude EDTA tube because what did I tell you? Potassium values will be falsely high and calcium values will be falsely low. I'm going to straight away exclude a gray top tube because gray top tube has got sodium fluoride. Sodium values will be falsely high. Potassium oxalate, so potassium values will be falsely high. Oxalate chelates calcium, so calcium values will be falsely low. So gray top tube is a strict no for electrolyte estimation. Green top tube, S can be used for electrolyte estimation, but what is that? That is plasma electrolyte estimation. So the answer has to be yellow. Okay. Now, what are the other tubes? Somebody was asking me about a red top tube. So what is the mnemonic that you can have for red top tube? The mnemonic for red top tube is RSS. All of you tell me what is the mnemonic for red top tube? It is RSS, wherein R stands for red. Okay, S stands for silica, and the next S stands for serum. Okay, red top tube is for serum separation because it has got silica. And what is silica? Silica is a clot activator. Okay, so for biochemistry, you can use either a red top tube or an yellow top tube because both have clot activators. But what is the difference? Yellow top tube has got a gel. So why do you need a gel? Suppose a sample has to be collected somewhere in the collection center and then it has to reach the lab. Okay, that will take a longer time period between sample collection and sample analysis. In that period, what will happen when cells undergo lysis? When cells undergo lysis, intracellular fluid of RBCs will contaminate the serum. Do you understand this? Would you want such contamination to happen before you estimate? No. In that case, if you want the sample to be transported for a prolonged period of time, or if you want the sample to be stored for a prolonged period of time, you collect blood sample in an yellow top tube which has a gel. Right? So when you collect blood sample in a gel tube, the blood sample will be staying above the gel when you collect it. After which, when you centrifuge it, the gel will move up. Okay, when you centrifuge it, the gel will move up and the gel stands like a mechanical barrier. Yeah, it moves up and it acts like a mechanical barrier between what in the bottom, between cells in the bottom and serum on top. Okay, between cells in the bottom and serum on top. So that even if the cell undergoes lysis, it does not contaminate the supernatant. So when will you use an yellow top tube, all of you? Yellow top tube needs to be used whenever serum estimation has to be done. But if the sample has to be transported for a prolonged period of time, or whenever the sample has to be stored for a prolonged period of time. That is the difference between the red top tube and yellow top tube. Is that clear? If it's clear, can I see a thumbs up, please, all of you? Yes. Now this tube, all of you tell me. We have already discussed about this tube. Lavender top tube. Thanks, Shivam. All of you. Can I see it from others also? So lavender top tube. What does it have? Lavender top tube has got K2 EDTA. Thanks, everybody. K2 EDTA or K3 EDTA. Okay, what will you use this for? This is used for complete blood count. Very good. It is used for HbA1c estimation. Excellent. And it is used for, come on, it is used for labile parameters like parathormone or ACTH or ammonia. Okay, so that's about lavender top tube. Look at this blue top tube. Have you all seen a blue top tube? Blue top tube is a citrated tube. Okay, what percentage citrate is it? 3.2% citrated tube. What is it used for? It is used for coagulation assays. C for C, citrated tube for coagulation assays, namely prothrombin time, activated partial thromboplastin time, fibrinogen assays, factor assays. Right? For all these purposes, we use 3.2% sodium citrate. So SS was mentioning ESR, right? For ESR, what is the percentage I told you? 3.8% sodium citrate, which has a black top, and that is used for ESR estimation. Clear? Now the next one. What is it? It's a green top tube. So what is a green top tube? As I told you, heparin. And when will you use a heparinized tube? Whenever a quicker analysis or stat biochemical analysis needs to be done, or whenever a cytogenetic testing, or whenever molecular diagnostics needs to be done. What is your doubt, Shivam? I'm not able to. Beta? Yes. So cytogenetic testing and molecular diagnostics, whenever DNA or RNA needs to be extracted. Okay, whenever DNA or RNA needs to be extracted, you have to use a heparinized tube. So heparinized tube is used for stat biochemical analysis, cytogenetics, and molecular diagnostics. So this is the tube that was asked in the question, yellow top tube. Please have this image as a visual memory, right? What do you see in this yellow top tube? It's a gel tube, and gel and clot activated tube. And what will use gel and clot activated tube for? All biochemical estimations which are done in a red top tube. But if you have to transport the sample or if you have to store the sample for a prolonged period of time. Okay, so that's about the various types of blood collection tubes. So what is the answer, all of you? Do you have any doubt? Right? So what is serum electrolyte estimation? What is a tube that is used? Yellow top tube. Now, which anticoagulant is ideal for blood sample for HbA1c estimation? The same exam had 2 questions on blood collection tubes, which you will be able to answer now, right? So HbA1c, what is a tube that you're going to use? EDTA. Excellent. So we are done with part 1. Let's start with part 2, carbohydrates. Please explain how many times. I mean, you don't have to be very worried about the number of times the tube has to be mixed, right? So it's mostly 6 to 8 times. I don't know if you all know this. I work in a blood collection tube manufacturing facility, right? So we have done enough testing on all these blood collection tubes and the additives. And irrespective of the additive that is used, 6 to 8 times mixing is ideal. Okay, minimum 6 times, maximum 8 times. Okay. Yeah, so let's start with part 2, carbohydrates. Okay. Yeah, this is enough for, yes, this is enough. Definitely. Okay. So the rate limiting enzyme of glycolysis is, what is the right answer, all of you? A very simple MCQ. Let's start from here. For carbohydrates, the rate limiting enzyme of glycolysis is phosphofructokinase 1. Okay, so one-liners, let's learn about rate limiting enzymes of all pathways in carbohydrate metabolism. Okay, let's start with glycolysis. Okay, so for glycolysis, what is a rate limiting enzyme? The rate limiting enzyme is phosphofructokinase 1. From now on, nobody should forget this. It's phosphofructokinase 1 for glycolysis. Okay. Missed my lecture in your first year. Yeah. Anyway, you're watching it now, right? Good. So glycolysis, the rate limiting enzyme is phosphofructokinase 1. And then for gluconeogenesis, what is the rate limiting enzyme for gluconeogenesis? The enzyme which reverses phosphofructokinase one step, it is fructose 1,6-bisphosphatase. For gluconeogenesis, it is fructose 1,6-bisphosphatase. What is the rate limiting enzyme for glycogen synthesis? Glycogen synthesis, the rate limiting enzyme is glycogen synthase. What is the rate limiting enzyme of glycogenolysis? For glycogenolysis, it is glycogen phosphorylase. For synthesis, it is glycogen synthase. For glycogenolysis, it is glycogen phosphorylase. What is the rate limiting enzyme of citric acid cycle? For citric acid cycle, the rate limiting enzyme is isocitrate dehydrogenase. Okay. For HMP shunt, it is glucose 6-phosphate dehydrogenase. Okay, so can we repeat this, all of you? Look at this table and repeat it along with me. For glycolysis, it is phosphofructokinase 1. For citric acid cycle, it is isocitrate dehydrogenase. For glycogen synthesis, it is glycogen synthase. For glycogenolysis, it is glycogen phosphorylase. For gluconeogenesis, it is fructose 1,6-bisphosphatase. For HMP shunt, it is glucose 6-phosphate dehydrogenase. Okay, so the rate limiting enzyme of glycolysis is phosphofructokinase 1. Fructose 1,6-bisphosphatase is the rate limiting enzyme of gluconeogenesis. Glycogen phosphorylase, good evening Akshay. Glycogen phosphorylase is the rate limiting enzyme of glycogenolysis. Glycogen synthase is the rate limiting enzyme of glycogen synthesis. Glucose and fructose are, right? So they often ask you questions related to isomerism. Let me help you answer such one-liners here. Glucose and fructose. Both glucose and fructose, very good. The answer is choice A, they are functional isomers. Both glucose and fructose have the same molecular formula C6H12O6. Glucose is an aldose, fructose is a ketose. Do you understand this? Glucose is an aldose and fructose is a ketose. So they have the same molecular formula, but they have different functional groups. So glucose and fructose are functional isomers. Okay. Now what will be optical isomers? Optical isomers include small d and small l. Okay. Optical isomerism is based on how they turn the plane polarized light. If an isomer turns a plane polarized light towards the right side, it's called a small d or dextrorotatory form. If it turns to the left side, it is small l or levorotatory form. So small d, small l are optical isomers. But please remember, capital D, capital L are different. Small d, small l are optical isomers. Capital D, capital L are enantiomers. Do you understand this? Capital D, capital L are enantiomers. Now, what are the examples of epimerism? Epimerism, please remember, glucose and mannose are epimers. Okay, glucose and mannose are epimers. At which position? How many ends do you see in mannose? Mannose has got 2 ends. So glucose and mannose are epimers at the second position. Glucose and galactose. Okay, glucose and galactose are epimers at which position? 4th position. Okay, so let's fill up this table. All of you answer this. Glucose and fructose are what kind of isomers? Glucose and fructose are functional isomers. Small d, small l are optical isomers. Capital D, capital L, please all of you answer. Capital D, capital L are enantiomers. Glucose and mannose are epimers at which position? Second position. Glucose and galactose are epimers at which position? 4th position. Okay. So that's about isomerism, which can be asked as one-liners. So tell me, glucose and fructose are what? Glucose and fructose are functional isomers. So let me repeat what I told you when I started the session. If you stay with me throughout the session, by the end would have learned at least 500 facts. Yeah, that's my assurance to you. So I want you to stay consistent with the same level of energy to memorize all facts as and when I tell you. Okay. Now, what are the products of anaerobic glycolysis? What is the right answer, all of you? Products of anaerobic glycolysis will be 2 lactate and 2 ATPs. Yeah, products of anaerobic glycolysis would be 2 lactate and 2 ATPs. Let me first tell you a bit about glycolysis, not the entire detail. Glycolysis is glucose lysis. So glycolysis is a process by which you split a 6-carbon compound called as glucose to form 2 products. And the 2 products that you get will differ depending upon whether the process occurs aerobically or anaerobically. When the process occurs aerobically, what are the products that you get? 2 pyruvate and 7 ATPs. So tell me, what are the products of aerobic glycolysis? 2 pyruvate and 7 ATPs. When the same process happens in the absence of oxygen, products formed are 2 molecules of lactate and 2 molecules of ATP. This is a simple fact that you should all remember, right? So what are the products of aerobic glycolysis? 2 pyruvate and 7 ATPs. Products of anaerobic glycolysis will be 2 lactate and 2 ATPs. Okay, this means you need to know all about energetics. You need to know about number of ATPs utilized or number of ATPs generated during all the pathways of metabolism. Okay, which can be asked as one-liners. So let's learn about that. Tell me, aerobic glycolysis. How many ATPs? Just now I told you aerobic glycolysis gives you 7 ATPs. Anaerobic glycolysis gives you how many ATPs? 2 ATPs. Citric acid cycle. Every cycle gives you 10 ATPs. Please memorize it. Every citric acid cycle gives you 10 ATPs. Complete oxidation of one molecule of glucose. What do you mean by complete oxidation? Complete oxidation any day is a fuel becoming carbon dioxide. So for glucose to become carbon dioxide, totally we get 32 ATPs. Do you understand this? Glucose on complete oxidation gives you 32 ATPs. Now, gluconeogenesis. Do you understand that gluconeogenesis is an anabolic pathway? Am I right? Gluconeogenesis is an anabolic pathway. And all anabolic pathways, what do? They need energy. So for you to be able to run gluconeogenesis, if you start from 2 molecules of pyruvate, okay, if you start from 2 molecules of pyruvate, then you have to invest 11 high energy phosphates. Please remember, gluconeogenesis is reversal of glycolysis. In glycolysis, you start from glucose, you split it into 2 molecules of pyruvate. In gluconeogenesis, you start with 2 molecules of pyruvate and you end up in 1 molecule of glucose. So if you start from 2 molecules of pyruvate, gluconeogenesis, you have to invest 11 high energy phosphates. But if you're starting from 2 molecules of lactate, yeah, if you're starting from 2 molecules of lactate, then you have to invest 6 high energy phosphates. Do you understand this? So for pyruvate, it is 11. From lactate, it is 6 high energy phosphates. Okay. Now, glycogen synthesis. In glycogen synthesis, for you to add 1 mole of glucose, right? For you to add 1 mole of glucose to the growing glycogen, you need to invest 3 high energy phosphates. Yes, hello. So for you to add 1 molecule of glucose to a growing glycogen, you have to invest what? 3 high energy phosphates. That's about glycogen synthesis. Now, palmitic acid oxidation. Palmitic acid with 16 carbon atoms on complete oxidation gives you 106 ATPs. Do you understand this? Palmitic acid on complete oxidation gives you 106 ATPs. Stearic acid on complete oxidation gives you 120 ATPs. Protein synthesis. For you to form a polypeptide chain, which is made up of amino acids, For you to attach one amino acid, you have to invest 4 high energy phosphates. For glycogen synthesis, for you to attach one molecule of glucose, it is 3 high energy phosphates. In protein synthesis, for you to attach one amino acid to a growing polypeptide chain, you need 4 high energy phosphates. Okay, are you clear? So can we repeat this? Aerobic glycolysis. How many ATPs do we get? 7 ATPs. Anaerobic glycolysis, you get 2 ATPs. Every citric acid cycle gives you 10 ATPs. Complete oxidation of one molecule of glucose gives you 32 ATPs. Gluconeogenesis, if you are starting from 2 molecules of pyruvate, it is 11 high energy phosphates. If you start from 2 molecules of lactate, it is 6 high energy phosphates. Glycogen synthesis, for you to attach one molecule of glucose, you have to invest. You all understand this? You have to invest 3 high energy phosphates. Palmitic acid on complete oxidation. All of you type this in the chat box, 106 ATPs. Stearic acid on complete oxidation gives you 120 ATPs. Protein synthesis, for attaching one amino acid, we have to invest 4 high energy phosphates. Okay, so that's all about energetics if you consider the entire biochemistry. Okay. Now, von Gierke's disease is caused by the defect of, right? So let's learn about, let's learn all possible one-liners related to glycogen storage disorders. Von Gierke's disease is caused by the defect of, intentionally I gave glucose 6-phosphate dehydrogenase first, right? I can see one person having chosen the wrong answer. So this is not glucose 6-phosphate dehydrogenase defect. What is it? Glucose 6-phosphatase defect. Okay, von Gierke's disease is caused by the defect of glucose 6-phosphatase. Okay, so let's learn about 9 types of glycogen storage disorders, the names and the enzymes which are defective. Okay, so what are the 9 types that we are going to learn about? Starting from type 0 till type 7. And along with type 7, I will also be telling you about type 11. Okay, because these are the named disorders. Let's start with type 0. So what is type 0? The name of the disorder is enzyme defect. Okay, so enzyme defect. What is the name of the disorder? Name of the disorder is von Gierke's disease. No, sorry. What is type 0? Type 0 is glycogen synthase deficiency. Now do you understand why it's called as type 0? Because it's a glycogen storage disorder without any glycogen storage. If glycogen synthase is defective, there can be no glycogen storage. That is why it's called as type 0, which is glycogen synthase deficiency. Type 1, 1 stands for von, right? 1 stands for von. So type 1 is von Gierke's disease caused by the defect of which enzyme? Glucose 6-phosphatase. Type 1 is von Gierke's disease caused by the defect of glucose 6-phosphatase. Type 2, Pompey's disease, right? Type 2 is Pompey's disease caused by the defect of acid maltase or alpha glucosidase. So in another half an hour, I will be telling you about Glycosphingolipidosis. Okay, when I tell you about Glycosphingolipidosis, I will tell you that beta glucosidase defect, right? Beta glucosidase defect causes Gaucher's disease. Alpha glucosidase defect causes Pompey's disease. So Pompey's disease is caused by the defect of acid maltase or alpha glucosidase. Type 3. Can you all tell me which is the third alphabet? Yeah, third alphabet is C. So C stands for Cory's disease. Type 3 is Cory's disease caused by the defect of C has to be followed by D. So Cory's disease is caused by the defect of D branching enzyme. Okay, C and D are over. So next it has to be A and B. So tell me what is type 4? Type 4 is Anderson's disease caused by the defect of branching enzyme. Okay, Anderson's disease is caused by the defect of branching enzyme. Type 5. right? 5 looks like the letter V, right? Roman letter 5 looks like the letter V. You invert V, write it twice. Yeah, you invert V, write it twice. What is it? It is M. So type 5, M stands for what? McArdle's disease. And McArdle's disease, M for M. So what is M? Muscle phosphorylase defect. Type 6 is Her's disease. Her's disease is caused by the defect of hepatic phosphorylase or liver phosphorylase. Do you understand this? Her's disease is hepatic phosphorylase or liver phosphorylase defect. Type 7 is Tarrow's disease. And Tarrow's disease is caused by the defect of phosphofructokinase 1, the rate limiting enzyme of glycolysis. And then type 11. What is type 11? It is Fanconi-Bickel syndrome. Okay, type 11 is Fanconi-Bickel syndrome, which is caused by the defect of GLUT2 transporters. Are you clear? So can you repeat this, all of you? What is type 0? Type 0 is glycogen synthase deficiency. All of you please repeat it. Type 0 is glycogen synthase deficiency. Type 1 is von Gierke's disease caused by the defect of glucose 6-phosphatase. Type 2, Pompey's disease, acid maltase or alpha glucosidase defect. Beta glucosidase defect causes Gaucher's. Type 3, third alphabet is C, Cory's disease caused by the defect of debranching enzyme. Type 4, Anderson's disease caused by the defect of branching enzyme. Type 5, McArdle's muscle phosphorylase defect. Type 6, Her's disease, hepatic phosphorylase or liver phosphorylase defect. Type 7 is Tarrow's disease, phosphofructokinase 1 defect. All of you, please don't get confused between Tarrow's and Fanconi-Bickel. Many a time students ask, is type 7 Fanconi-Bickel? No, type 11 is Fanconi-Bickel syndrome caused by the defect of GLUT2 transporters. Okay, so that's all about glycogen storage disorders, the names of those disorders and the enzymes which are defective. So von Gierke's disease is caused by the defect of glucose 6-phosphatase. Okay. Next one. Arsenate is an inhibitor of, right? So arsenate is an inhibitor of. In the name, do you see ATE? Arsenate, in the inhibitor's name, it ends with ATE. It inhibits phosphoglycerate kinase, right? Arsenate inhibits phosphoglycerate kinase. That way you can remember. So this means you have to learn about all inhibitors, right? So let me tell you about the various inhibitors acting on various enzymes, chemical inhibitors acting on various enzymes, okay? So the first enzyme is glyceraldehyde 3-phosphate dehydrogenase. Okay, glyceraldehyde 3-phosphate dehydrogenase is inhibited by iodoacetate. Have you memorized it? Glyceraldehyde 3-phosphate dehydrogenase is inhibited by iodoacetate. Phosphoglycerate kinase. How did I ask you to remember? Phosphoglycerate kinase is inhibited by arsenate. Okay. And then this we know. Did I tell you? Enolase. Enolase is inhibited by fluoride. That is why I told you great talk tube has sodium fluoride. So enolase is inhibited by fluoride. That's all about glycolytic enzyme defects or glycolytic enzyme inhibitors. Now about pyruvate dehydrogenase complex and alpha ketoglutarate dehydrogenase complex. Whenever you include pyruvate dehydrogenase in a list, you can close your I and include alpha ketoglutarate dehydrogenase as well, because both resemble each other in multiple ways, and actually in every possible way. So both pyruvate dehydrogenase and alpha ketoglutarate dehydrogenase are inhibited by arsenite. Yeah, they are inhibited by arsenite. Aconitase. Aconitase of citric acid cycle is inhibited by fluoroacetate. Aconitase is inhibited by fluoroacetate. If you're asking me how do I remember this, aconitase has got AC and then it is acetate AC. Okay, aconitase is inhibited by fluoroacetate. Succinate dehydrogenase is inhibited by malonate. Thank you. Happy Makar Sankranti. Thank you. So succinate dehydrogenase is inhibited by malonate. Are you clear? So these are the chemical inhibitors that can be possibly asked as one-liners. Okay. So can you repeat this? Glyceraldehyde 3-phosphate dehydrogenase is inhibited by iodoacetate. Phosphoglycerate kinase is inhibited by arsenate. Enolase is inhibited by fluoride. Pyruvate dehydrogenase and alpha ketoglutarate dehydrogenase both are inhibited by arsenite. Aconitase is inhibited by acetate. Which acetate? Fluoroacetate. Succinate dehydrogenase is inhibited by malonate. Yes, Shivam, you're right. Aconitase inhibiting fluoroacetate is an example of suicidal inhibition. Okay, it's an example of suicidal inhibition. Okay, so that's about inhibitors, chemical inhibitors acting at various enzyme levels. So tell me arsenate. Do you have any doubt now? Arsenate inhibits what? Phosphoglycerate kinase. Insulin dependent glucose transport is through. Have you seen MCQs related to GLUT transporters? Many a times, right? So insulin dependent glucose uptake happens through which transporter? Very good. GLUT4 transporter. Arsenic, right? Arsenic is a metal, right? And that exists either as arsenite or as arsenate. It cannot just be arsenic. Do you understand that? Yes. So GLUT4 transporter is the right answer. Okay. So let's learn about 5 GLUT transporters. GLUT1 till GLUT5. So first about GLUT1 transporter. GLUT1 transporter is present in RBCs and neurons. And this is the transporter that is also present in neoplastic cells. You're right, Shivam. Yes. So GLUT1 transporter is present in those cells for which glucose is indispensable. Glucose, you know, is indispensable for RBCs and neurons. When I say it's present there, I mean to say it exhibits very high affinity for glucose, so that even when there is low glucose, RBCs and neurons will be able to take up glucose. And neoplastic cells are super smart, right? That is why they're able to thrive and survive in any condition. So neoplastic cells know that they have to use glucose and they decided to use GLUT1 transporter with maximum affinity. So tell me GLUT1 transporter. Yes, high affinity is GLUT1. So GLUT1 is present in RBCs, neurons and in neoplastic cells. GLUT2 transporter is present in those cells which are related to glucose balance. Okay, it is related to glucose balance. So tell me what are the cells which are related to glucose balance? First, glucose has to be absorbed by enterocytes. Then glucose has to be stored by hepatocytes. And then pancreatic beta cells should be releasing insulin. And then glucose has to be reabsorbed by proximal convoluted tubular cells. So tell me, where do you have GLUT2 transporters? GLUT2 transporters are present in those cells which are related to glucose balance. What are the cells which are related to glucose balance? Enterocytes, hepatocytes, pancreatic beta cells and renal tubular cells. Now GLUT3 also exhibits higher affinity and GLUT3 is present in neurons and in placenta. Yeah, GLUT3 is present in neurons and in placenta. So if they ask you which transporter is present in RBCs, previously it was asked in NEET PG, your answer should be GLUT1. Now GLUT4, what is that you know about GLUT4? Insulin dependent glucose uptake. Right, very good Shivam, very good. Yes, all of you are answering about Warburg effect. Yes, you're all right. And because it's a one-liner session, I don't want to get deviated from what we are supposed to learn now. Okay, so insulin dependent glucose uptake happens in skeletal muscle, cardiac muscle and adipose tissue by GLUT4 transporter upregulation. right? Insulin dependent glucose uptake happens in skeletal muscle, cardiac muscle, and adipose tissue. For those of you who have not remembered this list, who are asking me how to remember this list, just know that insulin is an anabolic hormone. So it stimulates glucose uptake only into those cells where glucose can be used for anabolism. Insulin knows if glucose is taken up by skeletal muscle, it can be stored as glycogen. If it's taken up by cardiac muscle and by adipose tissue, that glucose can be stored as fat. And that is why insulin dependent glucose uptake happens in skeletal muscle, cardiac muscle, and adipose tissue by GLUT4 transporter upregulation. Okay. GLUT5. GLUT5 is related to fructose movement. So it is present in enterocytes for fructose absorption, and it is also present in seminal vesicle. Okay, GLUT5 is present in enterocytes and in seminal vesicle. So can you repeat this? GLUT1. All of you look at the board look at the slide and tell me. GLUT1 and GLUT3 transporters exhibit very high affinity. So GLUT1 is present in indispensable cells, namely RBCs and neurons. It's also present in neoplastic cells. And then what did I tell you? What happened? Yeah. And then GLUT2 transporters are present in those cells which are related to glucose balance, present in enterocytes, hepatocytes, pancreatic beta cells, and renal tubular cells. GLUT3 also exhibits higher affinity, so it's present in neurons as well as in placenta. GLUT4 is essential. Insulin-dependent glucose uptake happens in skeletal muscle, cardiac muscle, and adipose tissue by GLUT4 transporter upregulation. GLUT5 is related to fructose movement, and it is present in enterocytes as well as in seminal vesicles. Okay, so I want to tell you one more fact here. Okay, so the fact that I want you to know here is, when I say GLUT transporter, GLUT2 is present in enterocyte. Where do you think you see GLUT2 transporter? Do you think GLUT2 transporter is present along the apical side or along the basolateral side? GLUT2 is present along the basolateral side. Okay, so what is present along the apical side? Along the apical side, you have sodium glucose cotransporter 1. Okay, so glucose absorption along the intestine, along the apical side is by sodium glucose cotransporter 1, and along the basolateral side, it is by GLUT2 transporter. Okay. So we are done with clinical biochemistry. We are done with carbohydrates. Let's start learning lipids. Okay. So in lipids, I've started with an MCQ which has been previously asked. Okay. Surfactant is a. What is answer? Don't you all know that surfactant is dipalmitoyl phosphatidylcholine? Yeah, surfactant, the major chemical composition of surfactant is dipalmitoyl phosphatidylcholine, and phosphatidylcholine is lecithin, right? So what is the right answer, all of you? The right answer here is lecithin. So now I'm going to give you one-liners related to all these phospholipids. I will show you the chemical name, and let's write down the common name, and let's also write down the clinical condition related to those phospholipids. Okay. Let's start with phosphatidylcholine. What is the common name for phosphatidylcholine? Lecithin. And what is the clinical condition related to lecithin? Lecithin or dipalmitoyl phosphatidylcholine is the major chemical composition of surfactant that is released by type 2 pneumocytes. And this dipalmitoyl phosphatidylcholine reduces the surface tension of the lung. Thereby it reduces the work of breathing. Do you understand this? It reduces the surface tension of the lung. Thereby it reduces the work of breathing. But these type 2 pneumocytes get matured only during the late part of the last trimester. So tell me what will happen in premature infants. Premature infants do not have activated or active type 2 pneumocytes. Surfactant is not released. Surface tension of the lung is not reduced, and that causes infant respiratory distress syndrome. Okay, that causes infant respiratory distress syndrome. Let's worry about the PDF later, Mohammed. Can you please watch this and try to memorize all facts? I will ensure that you get it. Okay, I'll discuss with the team. Yeah, so now can we listen to this? So infant respiratory distress syndrome. That is a clinical condition related to lecithin. Now, phosphatidyl ethanolamine. Phosphatidyl ethanolamine is cephalin. Okay. And what is the clinical condition related to cephalin? Whenever there is an antibody that is directed against any of these phospholipids, that causes antiphospholipid antibody syndrome. Right? What do you call it as? Antiphospholipid antibody syndrome is caused by the antibodies that are directed against any of these phospholipids. Now, diphosphatidyl glycerol. What is diphosphatidyl glycerol? Very good. Excellent. I'm so happy that you have remembered Barth syndrome. So, diphosphatidyl glycerol is cardiolipin, and defective cardiolipin synthesis causes Barth syndrome. Okay, diphosphatidyl glycerol is cardiolipin. Defective cardiolipin synthesis causes Barth syndrome. So what do you expect as manifestations of Barth syndrome? Something should be happening to the heart. So Barth syndrome presents with dilated cardiomyopathy. Yeah, it presents with dilated cardiomyopathy, cardiac failure, and neutropenia. Do you understand this? It presents with dilated cardiomyopathy, cardiomegaly, cardiac failure, and neutropenia. All these are features of Barth syndrome wherein there is defective cardiolipin synthesis. Are you clear? So tell me, what is phosphatidylcholine? Lecithin. That's related to infant respiratory distress syndrome. Phosphatidyl ethanolamine is cephalin. And antibody against lecithin or cephalin or cardiolipin will cause antiphospholipid antibody syndrome. Diphosphatidyl glycerol is cardiolipin. Defective cardiolipin synthesis causes Barth syndrome. Okay. Now, the next MCQ is a very simple MCQ, truly a one-liner. Nutritionally essential fatty acids. There are two nutritionally essential fatty acids. One is linoleic acid. The other one is alpha-linolenic acid. Okay. One is linoleic acid. The other one is alpha-linolenic acid. So what is the right answer here? The right answer here is linoleic acid. It is not gamma-linolenic acid. It is alpha-linolenic acid. The lipid which accumulates in Fabry's diseases. So this is something is very important. Let's learn all about Glycosphingolipidosis as one-liners, right? In the regular video on PrepLadder and even in rapid revision, I've explained everything in detail, right? I've explained all about Glycosphingolipidosis. Now I'm going to tell you only one-liners related to Glycosphingolipidosis, okay? So the lipid which gets accumulated in Fabry's disease is globoside. Okay, what is answer? It is globoside. I remember it as global level fabric. Okay, I remember it as global level fabric. So all of us want to get dressed up, right? And we want to get dressed up with the global level fabric. So Fabry's disease is characterized by accumulation of globosides. Now let's learn about similarly sounding enzyme names and the disorders caused by defects of those enzymes. Okay, so what are those enzymes that we need to learn about? Beta galactosidase defect. Okay, beta galactosidase defect causes GM1 gangliosidosis and Krabs disease. Okay, beta galactosidase defect causes GM1 gangliosidosis and Krabs disease. Alpha galactosidase defect causes Fabry's disease. That is what we discussed now. I said globosides accumulate in this condition. So alpha galactosidase defect causes Fabry's disease. The next two, you should be able to tell me. Did I tell you beta glucosidase defect causes Gaucher's disease? Yeah. Beta glucosidase defect causes Gaucher's disease. Alpha glucosidase or acid maltase defect. What did I tell you just now? Alpha glucosidase or acid maltase defect causes Pompey's disease. Are you clear? I hope it's clear now. You should not get confused from now on. Beta galactosidase defect causes GM1 gangliosidosis and Krabs disease. Alpha galactosidase defect causes Fabry's disease. Beta glucosidase defect causes Gaucher's. Alpha glucosidase defect causes Pompey's disease. Now, let's learn about the lipids that accumulate in all these glycosphingolipidosis. Okay, so first about GM1 ganglioside accumulation. So GM1 gangliosidosis is the condition wherein which lipid accumulates? Obviously, GM1 ganglioside accumulates. Whereas in Tay-Sachs and in Sandoff, both in Tay-Sachs and Sandoff, GM2 gangliosides accumulate. That is why Tay-Sachs and Sandoff are collectively called as GM2 gangliosidosis. So how will you differentiate Tay-Sachs from Sandoff? In Tay-Sachs, there is an accumulation of only GM2 ganglioside. In Sandoff, there is an accumulation of both GM2 ganglioside and globocytes. Are you clear? In Sandoff, there is an accumulation of both GM2 ganglioside and globocyte. Sialidosis is the condition wherein GM3 ganglioside accumulates. So all of you tell me, GM1 ganglioside accumulates in GM1 gangliosidosis. GM2 ganglioside accumulates in Tay-Sachs and in Sandoff. In Sandoff, additionally, globocytes also accumulate. In sialidosis, GM3 gangliosides accumulate. Did I tell you about Fabry's disease? I said global level fabric, right? In Fabry's disease, what accumulates, all of you? Globocytes accumulate. Gaucher's disease is the condition wherein cerebrocytes accumulate. And that is why beta glucosidase is also called as beta glucosyl cerebrosidase. Don't you all know that? Beta glucosidase is also called as beta glucosyl cerebrosidase because the lipid that accumulates in Gaucher's disease is cerebrocyte. So let me repeat this for your benefit. All of you repeat it along with me. GM1 gangliosides accumulate in GM1 gangliosidosis. GM2 ganglioside accumulates in Tay-Sachs and in Sandoff. Additionally, in Sandoff, globocytes accumulate. GM3 gangliosides accumulate in neuraminidase deficiency or sialidosis. Globocytes accumulate in Fabry's disease. Cerebrocytes accumulate in Gaucher's disease. Okay. Now, few facts about these glycosphingolipidosis, or few mnemonics or shortcuts to remember about glycosphingolipidosis. I hope most of you know this, right? Have I already told you? I said no cherry red spots, right? No cherry red spots in KGF. So what does KGF stand for? KGF, we know, is a movie, right? I hope all of you have seen that movie, KGF. Here, what does KGF stand for? Krabs disease, Gaucher's disease, and Fabry's disease. Cherry red spot is not a feature of Krabs disease, Gaucher's disease, and Fabry's disease. The next one is no mental retardation. Mental retardation is never a feature of GF. Don't we always say that girlfriends are smart, right? You can never, you can never disappoint a GF, right? So girlfriends are smart. So no mental retardation GF. What does GF stand for? Gaucher's and Fabry's. The next fact is no organomegaly. Okay, organomegaly is never a feature of Tay-Sachs and Krabs. Okay, organomegaly is never a feature of Tay-Sachs disease and Krabs disease. So can you repeat this? Cherry red spot is not a feature of KGF. What does KGF stand for? Krabs disease, Gaucher's disease, and Fabry's disease. No mental retardation GF. What does GF stand for? Gaucher's and Fabry's. No organomegaly in Tay-Sachs disease and in Krabs disease. Okay, so these are the one-liners that you need to know about glycosphingolipidosis. So what is the lipid that accumulates in Fabry's disease? It is globocyte. The rate-limiting enzyme of fatty acid oxidation. All of you, did we learn all rate-limiting enzymes related to carbohydrate metabolism? Yes. Now it's time that we learn about rate-limiting enzymes of lipid metabolism. So fatty acids get oxidized in, excellent. Yes, the right answer is carnitine acyl transferase 1, the rate limiting enzyme of fatty acid oxidation. And if you're asking me how to remember this, please remember fatty acids get oxidized where? Please answer. Fatty acids get oxidized in mitochondria. And fatty acids cannot just like that enter into mitochondria. So you need a carrier. What is the carrier? The carrier is carnitine, right? And that is why the rate limiting enzyme of fatty acid oxidation is carnitine acyl transferase 1. So let's learn about rate limiting enzymes of all pathways of lipid metabolism. Okay, so let's start with fatty acid synthesis. The building block of fatty acid is acetyl-CoA. All fatty acids get synthesized from acetyl-CoA. Okay, I'll tell you an interesting fact. From acetyl-CoA, multiple acetyl-CoAs combine for you to get a very long fatty acid. Okay, and fatty acids on oxidation give rise to acetyl-CoA. It's like a cycle. Acetyl-CoA condenses to form fatty acids. Fatty acids on oxidation give rise to acetyl-CoA. So what is the rate limiting enzyme of fatty acid synthesis? It is acetyl-CoA carboxylase. The rate limiting enzyme of fatty acid synthesis is acetyl-CoA carboxylase. Fatty acid oxidation. Just now I told you carnitine acyl transferase 1. Cholesterol synthesis. The rate limiting enzyme is easy to remember. It is HMG-CoA reductase. Reason is statins. Don't you all know that statins reduce blood cholesterol level by inhibiting HMG-CoA reductase? You know that, right? Yes. So the rate limiting enzyme of cholesterol synthesis is HMG-CoA reductase. For ketone body synthesis, it is HMG-CoA lyase or HMG-CoA synthase. Okay, what is the rate limiting enzyme of ketone body synthesis? It is HMG-CoA lyase or HMG-CoA synthase. Bile acid synthesis. Please remember, cholesterol undergoes hydroxylation to form bile acids. So the rate limiting enzyme of bile acid synthesis should be a hydroxylase. Which hydroxylase is it? 7-alpha hydroxylase. So what is the rate limiting enzyme of bile acid synthesis? It is 7-alpha hydroxylase. Okay, can we repeat this, all of you? Please repeat it along with me. I don't think I have to reiterate it more. The only way to memorize all facts is to repeat it. Yeah, it is just repetition. There is no other shortcut to memory. So if you want to learn and memorize all these one-liners, it has to be repeated multiple times. So please repeat it along with me. For fatty acid synthesis, it is acetyl-CoA carboxylase. For fatty acid oxidation, it is carnitine acyl transferase 1. The rate limiting enzyme of cholesterol synthesis is HMG-CoA reductase. For ketone body synthesis, it is HMG-CoA lyase or HMG-CoA synthase. For bile acid synthesis, it is 7-alpha hydroxylase. Okay, so that's about rate limiting enzymes. We know the answer is carnitine acyl transferase 1. A simple one-liner. Yeah, you have to memorize it. The most commonly synthesized fatty acid by fatty acid synthase complex is palmitic acid. The one with 16 carbon atoms, that is the most commonly synthesized fatty acid by fatty acid synthase complex. Next. The number of cycles palmitic acid goes through for complete oxidation. Okay. Whenever they ask you number of cycles, the question can be on number of cycles for fatty acid synthesis or number of cycles for fatty acid oxidation. That is immaterial. The answer is always n by 2 minus 1. Very good. Excellent, Shivam. Yes, what is answer? The answer is n by 2 minus 1. What is n here? For palmitic acid, the n is 16. So 16 by 2 is 8. 8 minus 1 is 7. Do you understand this? For synthesis of palmitic acid also, it should go through 7 cycles. Oxidation of palmitic acid also, it should go through 7 cycles. It's always N by 2 minus 1. Primary ketone body is, yeah, this was also asked once. Which is the primary ketone body? The answer is acetoacetate. The primary ketone body is acetoacetate. Let me tell you few facts about ketone bodies because it's a favorite topic of NEET PG as well as INI-CET. The first fact about ketone bodies is ketone bodies are products of incomplete oxidation of fatty acids. Okay. Whenever fatty acids get oxidized, did I tell you all fatty acids give rise to acetyl-CoA? I told you, right? Whenever fatty acids get oxidized, they become acetyl-CoA molecules. Normally, acetyl-CoA enters into citric acid cycle. Okay. But sometimes acetyl-CoA will not be able to get into citric acid cycle. That is when acetyl-CoA condenses to form ketone bodies. When two acetyl-CoA molecules condense, that is called as acetoacetate. When two molecules of acetyl-CoA condense, then that forms acetoacetate. This acetoacetate then becomes acetone, or acetoacetate becomes beta hydroxybutyrate. So please don't forget this. What are ketone bodies? Okay, complete oxidation of fatty acid would give rise to carbon dioxide. What are ketone bodies? Ketone bodies are products of incomplete oxidation of fatty acids. And what are the three ketone bodies that we get? Acetoacetate, acetone, and beta hydroxybutyrate. Which is first formed? Acetoacetate is first formed. So that is called as the primary ketone body. So tell me, where do you oxidize all these fatty acids? Fatty acids always get oxidized in mitochondria, right? Fatty acids always get oxidized in mitochondria. So where are ketone bodies synthesized? Ketone bodies are synthesized in mitochondria, particularly liver mitochondria. Okay, ketone bodies are synthesized in liver mitochondria, but ketone bodies are utilized by extrahepatic tissues. Do you understand this? Ketone bodies cannot be used by liver. Ketone bodies can be used only by extrahepatic tissues. Why can't liver use ketone bodies? Liver cannot use ketone bodies because liver lacks thiophorase. Do you understand this? Liver cannot use ketone bodies because liver lacks thiophorase. So these are the facts that can be asked as one-liners as far as ketone bodies are concerned. Let me repeat all the facts that I told you. Please repeat it. Where are ketone bodies synthesized? Ketone bodies are synthesized in liver mitochondria. What are ketone bodies? Ketone bodies are products of incomplete oxidation of fatty acids. What are the three ketone bodies? Acetoacetate, acetone, and beta hydroxybutyrate. Which is the primary ketone body? Acetoacetate is the primary ketone body. Where are ketone bodies utilized? They are utilized by extrahepatic tissues. Why can't liver use ketone bodies? Because liver lacks thiophorase enzyme. Are you clear? Yes. What is it? Which is the ketone body that is formed in diabetic ketoacidosis? So in acute conditions of diabetic ketoacidosis, in severe and acute forms of diabetic ketoacidosis, it is beta hydroxybutyrate. Okay, in acute conditions, it is beta hydroxybutyrate. After you start the treatment, right? When you start insulin, then it becomes acetoacetate, then it disappears. I hope I have answered your question. In acute conditions of diabetic ketoacidosis, what is formed? Beta hydroxybutyric acid is formed. So the primary ketone body is acetoacetate. The organ which cannot utilize ketone body is, I told you, right? Can you all answer this, please? The organ which cannot use ketone body is liver. Good. Liver cannot use ketone bodies because of lack of. What did I tell you? Liver cannot use ketone bodies because of lack of thiophorase. Good. Ketone bodies are synthesized where? Ketone bodies are synthesized in liver mitochondria. Okay. So can we learn about the various pathways and the various suborganelles wherein these pathways happen? That can also be a one-liner, right? So this I hope everybody knows. Let's start with glycolysis, right? So did I tell you that glycolysis is one pathway that can happen even in the absence of oxygen? I told you, right? Glycolysis is one pathway that can happen even in the absence of oxygen. If a pathway is dependent on oxygen, then it happens in mitochondria. And if a pathway is not dependent on oxygen, then it happens in cytoplasm. So all of you tell me, where does glycolysis happen? It happens in cytoplasm. So in cytoplasm, glucose becomes pyruvate, right? Then what should be the fate of pyruvate? This pyruvate should enter into citric acid cycle. How does pyruvate enter into citric acid cycle? After pyruvate becomes acetyl-CoA. Which enzyme converts pyruvate into acetyl-CoA? Pyruvate dehydrogenase complex. So have you all memorized it? All of you answer. Pyruvate becomes acetyl-CoA in the presence of pyruvate dehydrogenase complex. Then this acetyl-CoA enters into citric acid cycle. Okay, and here I said, where does glycolysis happen? Glycolysis happens in cytoplasm. Whereas citric acid cycle should happen in mitochondria, right? Citric acid cycle should happen in mitochondria. So after pyruvate is formed, this pyruvate enters into mitochondria, wherein pyruvate dehydrogenase converts pyruvate into acetyl-CoA. Then acetyl-CoA enters into citric acid cycle. So glycolysis happens in cytoplasm. Where is pyruvate dehydrogenase complex present? I've shown you that within mitochondria. So PDH complex is present in mitochondria. Citric acid cycle happens in mitochondria. Okay. Glycogen metabolism. What do you mean by glycogen metabolism? It includes both glycogen synthesis and glycogenolysis. Both glycogen synthesis and glycogenolysis happen in cytoplasm. Okay. Fatty acid synthesis. Fatty acids also get synthesized in cytoplasm. Fatty acid oxidation. I said most of the oxidation processes happen in mitochondria. So fatty acids get oxidized in mitochondria. But very long chain fatty acids and branch chain fatty acids get oxidized in peroxisomes. So where do fatty acids get oxidized? Fatty acids get oxidized mostly in mitochondria, but very long chain and branch chain fatty acids get oxidized in peroxisomes. Cholesterol synthesis. Cholesterol is a steroid. Okay, all steroids get synthesized in smooth endoplasmic reticulum. S for S. Smooth endoplasmic reticulum is related to steroid synthesis. So cholesterol synthesis happens partly in cytoplasm and partly in smooth endoplasmic reticulum. Okay. Ketone body synthesis. Can you all answer? Have you already learnt about ketone body synthesis? What did I tell you? It happens in liver mitochondria. Good evening. Yeah. So ketone bodies get synthesized in mitochondria. Okay. The next, bile acid synthesis. Bile acids are also steroids. Right? Bile acids are also steroids. So where will they get synthesized? They get synthesized in smooth endoplasmic reticulum. Urea cycle and heme synthesis are two pathways which happen both in mitochondria and in cytoplasm. Okay, urea cycle and heme synthesis happen both in mitochondria and in cytoplasm. Okay, so can we repeat this, all of you? Please tell me glycolysis. Where does glycolysis happen? Cytoplasm. Pyruvate dehydrogenase complex and citric acid cycle are present in mitochondria. Glycogen synthesis and glycogenolysis happen in cytoplasm. Fatty acids get synthesized in cytoplasm. What did I tell you about fatty acid oxidation? Mostly in mitochondria. Exceptions would be branch chain fatty acid and very long chain fatty acids get oxidized in peroxisomes. Cholesterol synthesis and bile acid synthesis, both being steroids, get synthesized in smooth endoplasmic reticulum. Cholesterol synthesis happens partly in cytoplasm and partly in smooth endoplasmic reticulum. Ketone bodies get synthesized in mitochondria. Urea cycle and heme synthesis happen partly in mitochondria and partly in cytoplasm. Okay, so that's about pathways and suborganelles. So ketone bodies are synthesized in mitochondria. Serum cholesterol is elevated in. So did you all go through the latest NEET PG 2024 questions? In NEET PG 2024 put together, if you include both the morning session and in the evening session, there were 3 questions on hyperlipoproteinemia. 2 of which, 2 MCQs were on type 2A hyperlipoproteinemia. So tell me what is the right answer. Excellent, all of you. I'm very happy about those who are answering it right. And even those who are not able to answer this, please don't lose heart. You're here to learn. Okay, so remember, serum cholesterol is elevated in type 2A hyperlipoproteinemia. And that is why type 2A is otherwise called as familial hypercholesterolemia. Do you understand this? That's why type 2A is otherwise called as familial hypercholesterolemia, because in this condition, cholesterol level is elevated. Okay, so about Fredrickson's classification of hyperlipoproteinemias, I am going to classify those hyperlipoproteinemias. Okay, actually Fredrickson classified hyperlipoproteinemias into 6 types. Type 1, 2A, 2B, 3, 4 and 5. Yeah, tell me what are the 6 types. Type 1, 2A, 2B, and then we have 3, 4 and 5. So totally how many types of hyperlipoproteinemias do we have? 6 types. And let's classify these hyperlipoproteinemias into 3 categories depending upon whether cholesterol alone is elevated, or if triglyceride alone is elevated, or if both are elevated. Okay, so in the first category, wherein only cholesterol is elevated, that is type 2A. Yeah, please don't forget this. Only cholesterol is elevated in type 2A. And that is why I told you type 2A is otherwise called as familial hypercholesterolemia. High triglycerides are seen in type 1, type 4 and type 5. High triglycerides are seen in type 1, type 4 and type 5. So tell me what are the mixed conditions. What is left out, all of you? Left out is type 2B and 3. In type 2B and type 3, both cholesterol and triglycerides are elevated. Are you clear? So these are the one-liners that you need to remember. When is cholesterol alone elevated? Type 2A. When is triglyceride alone elevated? Type 1, 4 and 5. Both are elevated in type 2B and type 3. Okay. So the answer here is type 2A. So we are done with clinical biochemistry. We are done with carbohydrates. We are done with lipids. Let's learn one-liners in proteins. Okay. So after proteins, I'll tell you genetics and then miscellaneous topics. Okay. So the group that is present in tryptophan is, I have a mnemonic for tryptophan. It is TIA. Have you all heard of transient ischemic attack? Yeah, transient ischemic attack, TIA. T stands for tryptophan. And tryptophan has got an indole ring. Yeah, very good. Tryptophan has got an indole ring and it answers aldehyde test. Okay, tryptophan has got an indole ring and it answers aldehyde test. So what is the group that is present in tryptophan? It is indole. But this is not enough, right? If you just remember tryptophan has got an indole ring, you will not be able to answer any other MCQ asked in the same topic. So let me tell you few mnemonics related to amino acids, and then I will tell you about color reactions. Okay. So the mnemonics that we are going to learn about is, let's start with HIP. The first one is HIP. The second one is TIA, transient ischemic attack. Just now I told you. AGS, MPS, mucopolysaccharides, MPS. So these are the 4 mnemonics that you should remember. Okay. So what does HIP stand for, all of you? HIP. H stands for histidine. Histidine has got an imidazole ring. Okay. Histidine has got an imidazole ring and it answers Pauli's test. Now TIA. T stands for tryptophan. Tryptophan has an indole ring and it answers aldehyde test. Okay, tryptophan has got an indole ring and it answers aldehyde test. AGS, arginine, has guanidinium group. Okay, arginine has a guanidinium group and it answers Sakaguchi test. MPS, right? So MPS is the mnemonic that you can use for color reactions which give you red color. MPS refers to those color reactions which give you red color. M here stands for Millen's test. P stands for Pauli's test. S stands for Sakaguchi test. Okay, Millen's test, Pauli's test and Sakaguchi test, all these give you red color. Okay, so can you repeat this? The first one is HIP. Histidine has imidazole ring. It answers Pauli's test. Tryptophan has got an indole ring. It answers aldehyde test. Arginine has guanidinium group. It answers Sakaguchi test. And then we have MPS. What does MPS stand for? Millen's, Pauli's, Sakaguchi. All these give you red color reaction. Okay. Yeah, I will tell you about ninhydrin test also in this table. Okay, because they often ask you about all these color reactions and about the groups. Okay. So let's try to learn about all the groups and the color reactions now. Phenylalanine. Okay, all of you, as I told you, I think the session will continue for another 45 minutes or 45 minutes. Okay. So stay here for the next 45 minutes. You will be done with one-liners related to proteins, genetics, vitamins, and miscellaneous topics. Okay. So phenylalanine has got which group, all of you? Benzene. The group that is present is benzene. And the color reaction that it answers is xanthoproteic acid test. Okay, it is xanthoproteic acid test. And what color will you see? Yellow color, right? It gives you yellow color that then becomes orange. Have you all worked with nitric acid in your lab? Yeah. So whenever you work with nitric acid in the lab, you must have seen that your palms are getting stained yellow. It's because nitric acid reacts with aromatic amino acids that are present in the sweat. So what are the aromatic amino acids? Phenylalanine, tyrosine, tryptophan. Okay, phenylalanine, tyrosine, tryptophan. All these 3 aromatic amino acids react with nitric acid to give an yellow color that intensifies to form orange, and that's called as xanthoproteic acid test. Okay, now tyrosine. Tyrosine has a phenol group. Okay, tyrosine has a phenol group. This also answers xanthoproteic acid test, as I told you. This also gives you yellow color that intensifies to form orange. But apart from that, tyrosine also answers Millen's test. Okay, tyrosine also answers Millen's test. Can you all tell me which color I told you for Millen's? MPS, right? Millen's, Pauli's, Sakaguchi. All these give you which color? Red color. Yeah. Thanks for the wishes, Gokul. Yes. So Millen's give you red color. Okay. Tryptophan. Now you can start answering. What is the mnemonic I gave for tryptophan? For tryptophan, the mnemonic is TIA. So tryptophan has got an indole ring and it answers aldehyde test. And aldehyde test gives you purple color. Okay. What is the mnemonic for histidine? All of you type this in the chat box. The mnemonic that is given for histidine is HIP. What does HIP stand for? Histidine has got an imidazole group and it answers Pauli's test. And Pauli's test, tell me what color? MPS, it gives you red color. Excellent. Arginine. What is the mnemonic I gave for arginine? AGS. So arginine has got what group? Guanidinium group. It answers what color reaction? Sakaguchi test. I said Sakaguchi is also red color. Okay. Proline. Proline is the only amino acid, right? Proline is the only amino acid. And the color reaction is ninhydrin. Just now somebody was asking me about ninhydrin, right? So normally amino acids give you purple color with ninhydrin, but amino acids give you yellow color. Okay, so in ninhydrin reaction, if you see yellow color, it means it is proline. Okay, so that's all about amino acids. Is it that difficult? No, right? So all that you need to have is few mnemonics, few shortcuts, memorize it, repeat it multiple times, after which you will not say that biochemistry is volatile, right? So I've heard many students saying that biochemistry is volatile. I would say every subject for that matter would be volatile if you don't repeat it multiple times, right? All of the subjects you keep repeating it because you claim to like those subjects, right? But you say that you don't like biochemistry, so you don't repeat it multiple times. That is why you forget these facts. Otherwise, it's like any other subject, right? Actually, I would say biochemistry has less number of facts when compared to all other subjects. Okay, so let's overcome this, right? Let's overcome this myth that you have developed in your brain or in your mind, saying that biochemistry is volatile by repeating it multiple times. Okay, so get passionate about any subject for you to remember the facts related to the subject. Okay, so let's start this. Phenylalanine. You hate anatomy. Okay. So what is it? Pyrimidine. I'll tell you about that. Yeah. So pyrrolidine group is what you're asking. We will discuss about that. Okay. So phenylalanine. You hate medicine. Okay. So phenylalanine, what is the group that is present? Benzene. And what is the color reaction? The color reaction is xanthoprotic acid test. And what color do you see? It's not going to be volatile. Yes, you're right. So xanthoprotic acid test gives you yellow color that intensifies to form orange. Tyrosine has a phenol group. It also answers xanthoprotic test, protic acid test. But additionally, phenol also answers Millen's test. Millen's test is red color reaction. Tryptophan is TIA. Tryptophan has indole ring, aldehyde test, purple color. Histidine, HIP. Histidine has imidazole group. It answers Pauli's test, which is red color. Arginine, AGS, guanidinium group, Sakaguchi test. Proline is an amino acid, and this amino acid has pyrrolidine group. Okay, it has pyrrolidine group. It answers ninhydrin reaction in yellow color. Okay. Tertiary structure of a protein is studied by, right? So this has been asked twice previously. Tertiary structure of a protein is studied by X-ray crystallography. It is studied by X-ray crystallography. Sanger sequencing is for primary structure. Optical rotatory dispersion, that is for secondary structure. Very good, all of you. That's for secondary structure. SDS page is for quaternary structure. Okay, so now we are going to learn one-liners related to protein structure. And when I say one-liners, I will tell you two facts about every level of protein structure. First, I will tell you the linkage, and then I will tell you about the methods used. That's it. Okay, so what are the levels of protein structure? We have 5 levels of protein structure: primary, secondary, super secondary, tertiary, and quaternary. Can you repeat this? What are the 5 levels? Primary, secondary, super secondary, tertiary, and quaternary structure. Okay, so first about primary structure of a protein. This is nothing but amino acid sequence. Yeah, primary structure is nothing but amino acid sequence, which is linked by peptide linkage. So what is the linkage which stabilizes primary structure of a protein? It is peptide linkage. What are the methods used? Or what are the methods used for sequencing a protein? Sanger sequencing. So another one-liner is, who sequenced protein first? What should be your answer? Sanger. Which protein did he sequence first? Your answer should be insulin. Okay, Sanger was the first person to sequence protein, and the protein which he sequenced was insulin. So for primary structure, we have Sanger sequencing and Edman sequencing. Okay, now secondary structure of a protein. Secondary structure of a protein is stabilized by hydrogen bonds. Do you remember we have alpha helix and beta pleated sheet in secondary structure? Alpha helix is stabilized by intra-chain hydrogen bonding. Beta pleated sheet is stabilized by inter-chain hydrogen bonding. In either case, it is hydrogen bonding for secondary structure of a protein. What are the methods used for studying secondary structure? Secondary is 2, right? Secondary is 2. We have 2 eyes. Methods used have got something to do with eyes. So what are the methods used for studying secondary structure of a protein? One is optical rotatory dispersion, right? Optical rotatory dispersion. The other one is ocular dichorism. Okay. Optical rotatory dispersion, ocular dichorism are the two methods used for studying secondary structure of a protein. Super secondary structures, they are also stabilized by hydrogen bonds. And what are the methods used for studying super secondary structure? Interestingly, for studying both super secondary and tertiary structure, we have the same set of methods. So what are the methods? We have X-ray crystallography, UV spectroscopy, and NMR spectroscopy. Right? X-ray crystallography, UV spectroscopy, NMR spectroscopy are the methods used for studying both super secondary and tertiary structure of a protein. Now, what is the linkage which stabilizes tertiary structure? Tertiary structure is nothing but protein folding, right? And the major driving force for protein folding is hydrophobic interactions. Right? What is a major driving force for protein folding? It is hydrophobic interaction. That is the method, that is the linkage that stabilizes tertiary structure of a protein more. Okay. Quaternary structure. Quaternary structure, let me tell you one fact about quaternary structure because that is essential for you to answer the next one-liner that I'm going to discuss about. Not every protein exhibits quaternary structure. Only those proteins which have more than one polypeptide chain can exhibit a quaternary structure. For example, insulin can exhibit quaternary structure because insulin has got two polypeptide chains A and B connected by disulfide bridges. Don't you know that insulin has got two polypeptide chains A and B connected by disulfide bridges? So insulin, hemoglobin with 4 globin chains can all exhibit quaternary structure. So tell me, what is the linkage which stabilizes quaternary structure of a protein? Just now I told you it is disulfide bridge, right? It is disulfide bridge. Now, what is the method that is used for studying quaternary structure of a protein? Quaternary structure of a protein is studied by reducing type of SDS page. Just memorize it. The method that is used for studying quaternary structure of a protein is reducing type of SDS page. Okay. So let us repeat all that I've told you so far. Yeah. So tell me primary structure of a protein. Super secondary structure. Super secondary structure includes turns and loops. Right? It includes turns and loops. Super secondary and secondary are different. Secondary includes alpha helix. Okay. So primary structure. Can you all tell me what is the linkage which stabilizes primary structure of a protein? All of you answer. Primary structure of a protein is stabilized by peptide linkages. What are the methods used? Can I see answers in the chat box, please? Please start answering. Methods used for studying primary structure of a protein or methods used for sequencing a protein would be Sanger sequencing and Edman sequencing. Secondary structure is stabilized by hydrogen bonds. Alpha helix by intrachain, beta pleated sheet by interchain. What are the methods used? I asked you to remember secondary is 2Is, right? So it is optical rotatory dispersion and ocular dichorism. Okay, optical rotatory dispersion, ocular dichorism. Super secondary structure, all of you answer, hydrogen bonds again. And what are the methods used? X-ray crystallography, UV spectroscopy, NMR spectroscopy. Tertiary structure or protein folding is stabilized by hydrophobic interactions. Quaternary structure of a protein, two polypeptide chains are connected by disulfide bridges. What is the method used for studying quaternary structure of a protein? It is reducing type of SDS page. Antibodies do have quaternary structure. Is that your question? Yes. They have quaternary structure because there are two light chains and two heavy chains. So tertiary structure of a protein is studied by what should be our answer? X-ray crystallography. The protein which cannot exhibit quaternary structure is, tell me what is your answer? The protein which cannot exhibit quaternary structure is albumin, right? Albumin here or myoglobin. Because albumin has got only one polypeptide chain. How about LDH? LDH has got 4 polypeptide chains. Don't you know 4 subunits? H4, H3M1, H2M2. So LDH has more than one polypeptide chain. CK, 2 polypeptide chains. CKMM, CKMB and CKBB. Okay. And then insulin. Insulin has 2 polypeptide chains. Okay. Amino acids used for creatine synthesis are. Okay. So have you learnt a mnemonic to remember the amino acids which are necessary for creatine formation? Yeah. What is a mnemonic necessary to remember the amino acids used for creatine formation? It is GAME. Right. So what does GAME stand for? GAME stands for glycine, arginine, methionine. Okay, glycine, arginine, methionine. So what is the right answer here? The right answer here is tyrosine. Okay. Histone. Histone is an octamer, right? Histone is one polypeptide chain. Histone is one polypeptide chain. Histone octamer is different from histone. Do you get it? That's one polypeptide chain that cannot exhibit quaternary structure. So let's learn about specialized products that we get from amino acids, right? So all these are one-liners that can be asked. Specialized products obtained from amino acids. I'm going to tell you about glycine, tyrosine, tryptophan. Okay, what are the specialized products? Let's start with glycine. So from glycine, just now I told you creatine because I told you GAME, G stands for glycine. Okay. Creatine, heme. Glycine is necessary for heme synthesis. Don't you know that glycine reacts with succinyl-CoA to form delta ALA? That's the first step. So glycine is necessary for heme synthesis. And the same glycine is also necessary for purine ring formation. When we start genetics, which is the next topic, I will tell you about purine ring and pyrimidine ring formation. For now, glycine is necessary for creatine, heme, and purine formation. Okay. Tyrosine. Tyrosine is a precursor for neurotransmitters. What are the neurotransmitters that you get from tyrosine? Dopamine, norepinephrine, epinephrine. Right? Dopamine, norepinephrine, epinephrine are all from tyrosine. And from tyrosine, we get melanin. From tyrosine, we get thyroid hormone. So tell me, what are the specialized products that you get from tyrosine? Dopamine, norepinephrine, epinephrine. We also get melanin. We also get thyroid hormone. Okay. Tryptophan. Tryptophan is the precursor for serotonin. Because what is serotonin, all of you? 5-hydroxytryptamine. So from tryptophan, we get serotonin. We also get melatonin. Okay, serotonin, melatonin, and niacin. So these are the specialized products that you get from tryptophan. Are you clear? So from glycine, what do you get? Creatine, heme, purine formation. Of course, there are many other uses of glycine. Let's not get confused with that. Just remember, glycine is necessary for creatine, heme, and purine formation. Tyrosine is a precursor for dopamine, norepinephrine, epinephrine, melanin, and thyroid hormone. From tryptophan, you get serotonin, melatonin, and niacin. Okay. The most common non-toxic form of ammonia is, ammonia is toxic. Ammonia has to reach liver, where ammonia becomes urea, right? So the most common non-toxic form of ammonia, in which ammonia is transported from all tissues to reach the liver, is glutamate. So tell me, which is the most common non-toxic form of ammonia? It is glutamate. The two exceptions are neurons and muscle. Neurons form glutamine, muscle forms alanine. Yeah, all these are one-liners. The most common non-toxic form of ammonia is glutamate. Exception is neuron and muscle. Neurons form glutamine, muscle forms alanine. So let's start with genetics. So genetics is more conceptual, right? Generally, it's more conceptual. But there are few facts that can be asked as one-liners. I've chosen those facts. Let's start with purine source and pyrimidine source. Okay. So look at this. Purine ring is formed from all except. Can anybody choose the right answer here? Purine ring is formed from all except carbon monoxide. Okay. Carbon dioxide is necessary for purine ring formation, not carbon monoxide. And before I start telling you about the sources of atoms of purine ring and pyrimidine ring, let me tell you a simple fact about purines and pyrimidines, right? So purine has a smaller name, but it has a bigger structure. Yeah, purine has a smaller name, it has a bigger structure. It has 2 rings and 9 atoms. Whereas pyrimidines with a longer name, they have a smaller structure. They have single ring and 6 atoms. Okay. Now, what are the sources of atoms of purine ring? You have to tell me the sources of all 9 atoms of purine ring. So, what are the sources? Let's start with the first one. In purine ring N1, which is the first alphabet? The first alphabet is A. So N1 is from aspartate. Are you clear? N1 is from aspartate. C2C8. Okay. Don't you know that 2 into 4 is 8? Maths, 2 into 4 is 8. 4 is tetra, right? So C2 and C8 are from tetrahydrofolate derivatives. Okay, C2 and C8 are from tetrahydrofolate derivatives. You can remember it as 2 into 4 is 8. Okay. Then N3 and N9. N3 and N9 are from glutamine. It's going to be easy to remember because N1 of purine and N1 of pyrimidine are from aspartate. No change at all. Do you understand this? N1 of purine, N1 of pyrimidine are from aspartate. N3 of purine and N3 of pyrimidine are from glutamine. Both are same. Okay. Now what is left out? C4. C4, C5, N7. Okay, C4, C5, N7. All these are from glycine. That's why I told you glycine is necessary for purine ring formation. Did I tell you? Glycine is necessary for creatine, heme, and purine ring. So C4, C5, and N7 are from glycine. The only one that is left out is C6. C6 is from carbon dioxide. Okay, C6 of purine ring is from carbon dioxide. So can you all repeat this? N1. N1 is from aspartate. C2 and C8 are from tetrahydrofolate derivatives. N3 and N9 are from glutamine. C4, C5 and N7 from glycine. And C6 is from carbon dioxide. Okay. Now, pyrimidine ring. So how many atoms are there in pyrimidine ring? Please type it in the chat box. Pyrimidine ring has got 6 atoms. So what are the sources of 6 atoms of pyrimidine ring? Already did I tell you N1 is from aspartate? I told you. And then I said N3 is from glutamine. Right? N1 from aspartate, N3 from glutamine. Between the two, C2 is from carbon dioxide. Easy, right? C2 is from CO2. Okay. Now what is remaining? Remaining is C4, C5, C6. C4, C5, C6, all these are from aspartate. Got it? So can you repeat this? For pyrimidine ring, N1, C4, C5, C6 from aspartate. C2 is from carbon dioxide. N3 is from glutamine. Okay. So that is about sources of atoms of purine ring and that of pyrimidine ring. So purine ring is formed from all except your answer should be carbon monoxide. Defect of mismatch repair causes. What is the right answer? Have you seen questions related to this topic? Yeah. So DNA repair defects are always asked about. So mismatch repair defect. Mismatch has got double M. Defect causes double C. Okay, mismatch repair, it has got double M. Defect causes double C. What is double C? HNPCC. Okay, so let's learn about all repair defects. So what are the repairs that we have? We have first base excision repair. Second one is mismatch repair. Third one is nucleotide excision repair. And the last one is double-stranded DNA break repair. Right? So we have 4 repair mechanisms. What are the 4 repair mechanisms? One is base excision repair, mismatch repair, nucleotide excision repair, and the last one is double-stranded DNA break repair. Now, defects of these disorders. Did I already tell you that mismatch repair, double M defect causes double C? What is double C? Hereditary non-polyposis colon cancer. Okay. Nucleotide excision repair defect. Excision has got an X, right? Excision has got an X. Defect causes X xeroderma pigmentosa. Okay, nucleotide excision repair defect causes xeroderma pigmentosa and Cockayne syndrome. So nucleotide excision repair defect causes xeroderma pigmentosa and Cockayne syndrome. Now about double-stranded DNA break repair defects. Double-stranded DNA break repair defects cause ABF disorder. The mnemonic that you can have is ABF. What does ABF stand for? A stands for ataxia telangiectasia. B stands for Bloom syndrome. F stands for Fanconi's anemia. Okay, ataxia telangiectasia, Bloom syndrome, and Fanconi's anemia. They're all caused by defects of double-stranded DNA break repair. Okay, and I know that double-stranded DNA break repair can be done in 2 ways. Okay, break repair can be done in 2 ways. One is non-homologous enjoining. The other one is homologous DNA repair. Please remember, double-stranded DNA break repair can be done in 2 ways. One is non-homologous enjoining. The other one is homologous DNA repair. Out of these disorders, the first 2 are caused by the defects of non-homologous enjoining. Okay, non-homologous enjoining repair defect causes ataxia telangiectasia and Bloom syndrome. Additionally, non-homologous enjoining defect also causes severe combined immunodeficiency. Non-homologous enjoining defect also causes severe combined immunodeficiency. homologous DNA repair defect causes Fanconi's anemia and human breast and ovarian cancer. Okay, homologous DNA repair defect causes Fanconi's anemia and human breast and ovarian cancer. Have you all learnt about BRCA1? Say yes or no. Have you all learnt about BRCA1? Yes, BRCA1 mutation makes the person prone to present with breast cancer, ovarian cancer, and colon cancer. And that BRCA1 is a protein that is involved in homologous DNA repair. And that's why I said homologous DNA repair defect causes human breast and ovarian cancer. Okay, so can we repeat it, all of you? Repeat it along with me. What did I tell you? Mismatch repair defect, double M. Defect causes double C. Hereditary non-polyposis, colon cancer. Nucleotide excision repair has got an X. Defect causes xeroderma pigmentosa and Cockayne syndrome. Double-stranded DNA break repair defect causes ABF. What does ABF stand for? Ataxia telangiectasia, Bloom syndrome, and Fanconi's anemia. To make it more complex, if they ask you non-homologous end-joining defect causes what? The first two, ataxia telangiectasia, Bloom syndrome. So please listen to this. Ataxia telangiectasia is caused by the defect of ATM protein, and this ATM protein is involved both in non-homologous end joining and homologous DNA repair. So you can have ataxia telangiectasia in both the list. Okay, non-homologous end joining defect and homologous DNA repair defect. That is ataxia telangiectasia. Bloom syndrome and severe combined immunodeficiency caused by the defect of non-homologous end joining. Homologous DNA repair defect causes Fanconi's anemia and human breast and ovarian cancer. Okay. Okay. So the next question is function of DNA polymerase delta accept. They've often asked you this question. Okazaki fragments, right? Okazaki fragments are synthesized by, right? What is the question? Okazaki fragments are synthesized by. Your answer should be DNA polymerase delta. Okay. So function of DNA polymerase delta accept. Your answer should be RNA primase. Okay, which means yes, delta is related to leading strand synthesis. It's related to Okazaki fragment synthesis. It is also related to gap filling. Okay, so now I'm going to tell you about all prokaryotic and eukaryotic DNA polymerases. Prokaryotic DNA polymerases. So let me tell you all this. If you learn all these facts all by yourself, right, it will take forever. Yeah, it will take forever because you'll have to complete the entire biochemistry and then write down all these facts and then you should go through it, right? And I know you don't have that luxury of time. Okay, and that is why PrepLadder has organized for this 100 one-liner session. I would say this 100 one-liner session is a boon to everybody who's preparing for any of the upcoming competitive exams. Okay, so if you're here watching this session, yes, it is not easy. Yes, you will feel overwhelmed, but that doesn't mean you should go off. Okay, so stay put, watch the session completely. At the end of the session, you'll feel happy about what you have done for yourself. Okay, and not just the session, watch the entire series of one-liners, right? Already there are few YouTube videos that are over and there are few which are lined up. So don't miss any of these videos. Watch all these videos because though we say that conceptual MCQ contribution is more now, that does not mean there is no one-liner, right? Still, majority of the MCQs are one-liner based. Okay, so this is a boon for all of you. Please watch this continuously and memorize it along with me. Don't think that you'll watch the session, get the PDF, I will memorize it later. That never happens. Right? How many PDFs do you all have for yourselves? I know you have n number of PDFs. How many times do you get the time to go back and revise? Not many a times. So when you watch a video, along with that, memorize all facts as well. Okay. So coming back to this, for you to get an understanding of DNA polymerases, we have prokaryotic DNA polymerases and eukaryotic DNA polymerases. Prokaryotic DNA polymerases include DNA polymerase type 1, type 2, type 3. Eukaryotic DNA polymerases include alpha, beta, epsilon, gamma, and delta. Okay, and before we learn about functions of all these DNA polymerases, just remember that replication is a bidirectional process. Do you understand this? Replication is a bidirectional process because whenever there is a replication, there is unwinding of both the strands. After unwinding, all enzymes start acting from the center. From the center, one set of enzymes act in one direction, another set of enzymes act in the other direction. For an enzyme system which is acting in one direction, against one strand, they will be able to synthesize a new strand continuously. Yeah, for an enzyme system which is acting in one direction, the enzyme against one strand will be able to synthesize a new strand continuously. That strand against which your DNA polymerase is able to synthesize a new strand continuously will be called as a leading strand. So tell me, what is a leading strand? The strand against which a DNA polymerase is able to synthesize a new strand continuously will be called as a leading strand. Whereas against the other strand, it will be able to synthesize a new strand only discontinuously. And that strand is called as lagging strand. And against this lagging strand, those short fragments that you synthesize with RNA primers attached to DNA, right? Against those lagging strands, those short fragments that you synthesize with RNA primer attached to DNA are called as Okazaki fragments. So have you understood what is leading strand and what is lagging strand? Continuous synthesis happens against leading strand. Discontinuous synthesis happens against lagging strand. Those short fragments with RNA primer attached to DNA are called as Okazaki fragments. With this understanding, let's learn about functions of prokaryotic DNA polymerases. So what are the prokaryotic DNA polymerases? 1, 2, and 3. Let's start with 3. 3 helps in leading strand synthesis. All of you repeat it. What is the function of 3? 3 helps in leading strand synthesis and Okazaki fragment synthesis. Okay, 3 helps in leading strand synthesis and Okazaki fragment synthesis. What is the function of DNA polymerase 1? So against lagging strand, when I say there is an RNA primer that is attached to DNA, what are you supposed to do? You're supposed to be removing the RNA primer. What removes RNA primer? DNA polymerase 1 removes RNA primer. Okay. After polymerase 1 removes RNA primer, there is a gap that is created. So what fills the gap? The same DNA polymerase 1 does not only remove the RNA primer, it also fills the gap. So tell me, what is the function of DNA polymerase 1? It removes RNA primer and it fills the gap during lagging strand synthesis. Okay, it fills the gap during lagging strand synthesis. That's about the function of 3 and 1. So what is the function of 2? 2 helps in proofreading and repair activity. Okay, 2 helps in proofreading and repair activity. So can you all repeat this? What is the function of 3? 3 helps in leading strand synthesis and Okazaki fragment synthesis. 1 removes RNA primer, fills the gap during lagging strand synthesis. 2 helps in proofreading and repair activity. That's all about DNA polymerases in prokaryotes. Now, what are the eukaryotic DNA polymerases? Eukaryotic DNA polymerases include alpha, beta, epsilon, gamma, and delta. Okay, let's start with DNA polymerase alpha. DNA polymerase alpha is RNA primase. Okay, DNA polymerase alpha is RNA primase. beta is like 2. Okay, beta is like 2 of prokaryotes. So what does beta help you in? Beta helps you in proofreading and repair activity. Okay, and then epsilon. Epsilon is like 3 of prokaryotes. So tell me, what did I tell you 3 does? I said 3 helps in leading strand synthesis. So epsilon helps in initiating the leading strand synthesis. Okay, epsilon helps in initiating the leading strand synthesis. All other functions are done by delta. So tell me, what is the function of delta? Delta helps in completing the leading strand synthesis. It helps in Okazaki fragment synthesis. Okay, and it removes the RNA primer. Every other function, it removes RNA primer and it fills the gap during lagging strand synthesis. Do you understand this? So DNA polymerase delta completes all functions. So what does it do? It completes the leading strand synthesis. It helps in Okazaki fragment synthesis. It removes RNA primer and it fills the gap during lagging strand synthesis. So if they ask you, Okazaki fragments are synthesized by, what will be your answer? DNA polymerase delta. Okay. Gamma helps you in mitochondrial DNA synthesis. Got it? So gamma helps in mitochondrial DNA synthesis. So can you repeat this? What is the function of alpha, all of you? Alpha helps in RNA primase activity. Though you call it as DNA polymerase alpha, it is RNA primase. Beta is like 2 of prokaryotes. So beta helps in proofreading and repair activity. 3 initiates leading strand synthesis. Epsilon helps in initiating leading strand synthesis. Gamma helps in mitochondrial DNA synthesis. Delta completes the leading strand synthesis. Okazaki fragment synthesis removes RNA primer and it fills the gap during lagging strand synthesis. Are you clear? So if it's clear to all of you, can I see a thumbs up or some likes on this video for me to understand that you're all following this session? Because I've been continuously teaching you probably for the last, I don't know how many hours. So can I see some thumbs up? Yeah. Thanks, Shivam. So now about siRNA. Can you all answer? siRNA causes what? siRNA causes gene knockdown. Okay, siRNA causes gene knockdown. Okay, so let me tell you about knockdown, knockout, and knock-in, and that will be the last question for genetics, after which we'll start discussing vitamins and miscellaneous topics. Okay, so siRNA helps in gene knockdown. What is your question? Yes, thanks all of you. So siRNA, all that you need to know is siRNA small interference RNA. Okay, it is small interference RNA in the sense it interferes with gene expression. Do you understand this? siRNA is small interference RNA that interferes with gene expression. First, what is gene expression? You all know that genes on transcription give rise to mRNAs. Right? Genes on transcription give rise to mRNAs. These mRNAs on translation give rise to proteins. Okay, so this is called as gene expression. So all of you tell me, what is gene expression? Genes on transcription giving rise to mRNAs. mRNAs on translation giving rise to protein will be called as gene expression. So whenever you say small interference RNAs interfere with gene expression, you should say, where do they interfere? They interfere at the translation level. Do you understand this? They interfere at the translation level. So how do they interfere? These siRNAs, like any other RNA, they have their own sequences. And suppose these siRNAs find complementary sequences on any of the fully formed mRNAs, they go and hybridize with those mRNAs. and they form a double-stranded RNA structure. And once double-stranded RNA structure is formed, a ribosome, which is translating this mRNA, takes this as a signal. It takes this as a signal that this mRNA has to be fragmented. So what does ribosome do? Ribosome recruits an endonuclease, and that endonuclease makes multiple fragments out of the mRNA. Now that the mRNA is fragmented, it is no more translated. Do you understand this? mRNA is no more translated. When translation does not happen, there is down regulation of gene expression. That is why it is called as gene knockdown. Yeah, when there is down regulation of gene expression, that is called as gene knockdown. So for your benefit, I am repeating this so that you don't forget this in your exam. I said siRNAs or small interference RNAs, and they interfere with the gene expression at the translation level. How do they interfere at the translation level? These siRNAs, they go and bind if they find complementary sequences on any of the fully formed mRNAs, forming a double-stranded RNA structure. When a double-stranded RNA is formed, ribosome gets a signal. It's a signal that the ribosome receives to say that this mRNA has to be fragmented. So ribosome fragments the mRNA, so no more translation, the protein is not expressed. So there is down regulation of gene expression. That is why we call it as gene knockdown. Okay. Now what is knockout and knock in? Gene knockout is removal of the defective gene. Gene knock-in is replacing the defective gene with a normal gene. Do you understand this? So in gene knockdown, you don't even reach the gene, right? You don't even go to the gene. You only down-regulate the gene expression. Whereas knockout and knock-in, you go to the gene and you edit the gene. So knockout and knock-in are two ways by which you can edit the gene. Okay, so knockout and knock-in. Knockout is you're editing the gene to remove the defective gene. In knock-in, you don't only remove the defective gene, you replace it with a normal gene. Which is better? Knock-in is always better. Okay, and both this knockout and knock-in are brought about by CRISPR-mediated gene editing. Both knockout and knock-in are brought about by CRISPR-mediated gene editing, wherein there is an endonuclease which creates a double-stranded DNA break. In CRISPR-Cas enzyme system, there is a Cas enzyme which creates a double-stranded DNA break. And I said whenever there is a double-stranded DNA break, the repair can be done in two ways. One is non-homologous enjoining. The other one is homologous DNA repair. I told you, right? Double-stranded DNA break is repaired by non-homologous enjoining or by homologous DNA repair. Whenever there is non-homologous enjoining, you can only remove the defective gene. That's called as knockout. In homologous DNA repair, you remove the defective gene, you replace it with a normal gene. That's called as knock-in. Okay? To summarize, what are the one-liners that can be asked here? Gene knockdown is done by siRNA or small interference RNA. Gene knockout is done by non-homologous enjoining. Gene knock-in is done by homologous DNA repair. Okay, knockout and knock-in are two ways by which you can edit the gene. Okay, so that's about knockdown, knockout, and knock-in. So now about vitamins. So what are the one-liners in vitamins? Which of the following is a sulfur-containing vitamin? Give me a second. Can you see me? Yeah. So which of the following is a, thanks all of you. Happy Pongal and happy Makar Sankranti. Okay, so which of the following is a sulfur-containing vitamin? And this is a very simple one-liner which I want everybody here to memorize. The two sulfur-containing vitamins are number 1, thiamine, and number 2, biotin. Okay, number 1 is thiamine and number 2 is biotin. Can you all see me? The next one is carboxylases require. Yes, carboxylases require. What is answer? The answer is biotin. Okay, so please don't forget this. Carboxylases have a requirement which is biotin. And let's learn about vitamins, coenzyme forms, and the coenzyme role. Which vitamin is necessary for which enzyme, right? That's a very simple question that can be asked as one-liners. We are going to learn about all vitamins, their coenzyme forms, and their coenzyme roles. And I'm going to start with thiamine. Okay, which is the coenzyme form of thiamine? Can you all answer? The coenzyme form of thiamine is thiamine pyrophosphate. And what are the coenzyme roles of thiamine? Thiamine pyrophosphate is necessary for pyruvate dehydrogenase complex. Please memorize it. It's necessary for pyruvate dehydrogenase complex. And when I started the session, I said, whenever you include pyruvate dehydrogenase complex, in that list, you should also include alpha ketoglutarate dehydrogenase complex. So pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase. The third one is branched chain keto acid dehydrogenase. Have you learned that maple syrup urine disease is caused by the defect of branched chain keto acid dehydrogenase enzyme? Yeah, that is also dependent on thiamine. And then trans ketolase. Okay, trans ketolase is also dependent on thiamine. So can you all repeat this, all of you? So this will be giving you a summary of all the vitamins, their coenzyme forms and coenzyme roles. So repeat it along with me. Thiamine is acting as a coenzyme. Which coenzyme form? Thiamine pyrophosphate. For which enzyme? Pyruvate dehydrogenase, alpha ketoglutarate dehydrogenase, branched chain keto acid dehydrogenase, defect of which causes maple syrup urine disease, and trans ketolase. Okay. Now about B2. B2 or riboflavin. So what are the coenzyme forms of riboflavin? Riboflavin coenzyme forms include FMN and FAD. Okay, FMN and FAD. What are the FAD dependent enzymes? This is often asked about. FAD dependent enzymes include succinate dehydrogenase. Number one is succinate dehydrogenase. Number two, acyl-CoA dehydrogenase. Okay, acyl-CoA dehydrogenase of fatty acid oxidation. Third is mitochondrial glycerol 3-phosphate dehydrogenase. So tell me, what are the FADH2 linked dehydrogenases? Succinate dehydrogenase of citric acid cycling, acyl-CoA dehydrogenase of fatty acid oxidation, mitochondrial glycerol 3-phosphate dehydrogenase. The next one is vitamin B3, right? So what are the coenzyme forms of B3? B3, you know, is niacin. So what are the coenzyme forms of niacin? Niacin mononucleotide, niacin adenine dinucleotide, niacin adenine dinucleotide phosphate, NMN, NAD, NADP. All these are coenzyme forms of niacin. Okay, and here you know NAD is necessary as a coenzyme for many enzymes wherein NADH is formed. Now, NADP is necessary as a coenzyme for limited number of enzymes which can be asked as MCQs. So tell me, what are the enzymes which use NADP instead of the usual NAD, right? So NADP dependent enzymes are present in HMP shunt. Please memorize it. It's present in HMP shunt. Cytoplasmic isocitrate dehydrogenase and malic enzyme which converts malate to pyruvate. Please memorize it. What are the NADP dependent enzymes? Most of the enzymes use NAD. NADP dependent enzymes include HMP shunt, cytoplasmic isocitrate dehydrogenase, and malic enzyme which converts malate to pyruvate. Okay, that's about coenzyme forms of niacin. Now, B6. Okay, so B6 is often asked about. The coenzyme form of B6 is pyridoxal phosphate. And this pyridoxal phosphate is necessary for transaminases. Like what I told you, biotin is necessary for carboxylases. B6 or pyridoxal phosphate is necessary for transaminases, decarboxylases. Okay, transaminases, decarboxylases. It is also necessary for kynurenase. Kynurenase, which helps in the conversion of tryptophan to niacin. And then cystathionin beta synthase. Okay, cystathionin beta synthase. So I'm repeating this for your benefit. All of you tell me B6 or pyridoxal phosphate is necessary for transaminases, decarboxylases, kynurenase, and cystathionin beta synthase. B12. What are the coenzyme forms of B12? Adenosyl B12 and methyl B12. Right? What are the coenzyme forms of B12? Adenosyl B12 and methyl B12. Adenosyl B12 acts as a coenzyme for methyl malonyl CoA mutase. Okay, adenosyl B12 is necessary as a coenzyme for methyl malonyl CoA mutase. Methyl B12 is necessary for methionine synthase. Okay, methyl malonyl CoA mutase and methionine synthase. That's about B12. Okay. Vitamin C. Vitamin C is necessary for hydroxylases. Right? Vitamin C is necessary for hydroxylases. What are the hydroxylases? Prolyl hydroxylase, lysyl hydroxylase. Okay, prolyl hydroxylase and lysyl hydroxylases need vitamin C, and that is why vitamin C is necessary for collagen maturation. Okay, vitamin K. Vitamin K is necessary as a coenzyme for gamma carboxylase. You know, gamma carboxylase is necessary for activating clotting factors 2, 7, 9, 10. Remember? So, vitamin K is necessary for gamma carboxylases. Biotin, please answer. Biotin is necessary for carboxylases. Are you clear? Yeah. So if you remember or if you memorize this table, it means you have already learned about most of the vitamins coenzyme roles. Okay. So thiamine is active as thiamine pyrophosphate, necessary for PDH. Repeat it. This repetition is for you. PDH, alpha ketoglutarate dehydrogenase, branch chain keto acid dehydrogenase, and transketolase. B1. Okay. B2. You have to know FAD dependent enzymes. What are the FAD dependent enzymes? Succinate dehydrogenase, acyl CoA dehydrogenase, and mitochondrial glycerol 3-phosphate dehydrogenase. Niacin, you have to remember NADP dependent enzymes. What are the NADP dependent enzymes? HMP shunt, cytoplasmic isocitrate dehydrogenase, and malic enzyme. Okay. And then we have B6. B6 is something which is often asked about. So B6 is necessary for transaminases, decarboxylases, kynurenase, and cystathionin beta synthase. B12. Just remember B12 has got two coenzyme forms, adenosyl B12 and methyl B12. Adenosyl B12 is necessary for methyl malonyl CoA mutase. Methyl B12 is necessary for methionine synthase. And then vitamin C for prolyl hydroxylase and lysyl hydroxylase. That is why vitamin C is necessary for collagen cross-linkage formation. Vitamin K is necessary for gamma carboxylases. Biotin for carboxylases. Okay. Thiamine deficiency is diagnosed by estimation of what? Okay, so again, deficiency diagnostic tests are always asked. Just now I told you thiamine is necessary as a coenzyme for transketolase. right? It's necessary for transketolase. So thiamine deficiency can be diagnosed by RBC transketolase activity. Okay. So can we learn about all vitamin deficiency diagnostic tests? Okay. So let's start with what we know already, thiamine. So tell me for thiamine, what do you estimate? RBC transketolase activity. Very good. And then B2. B2 is riboflavin. Just remember, ribbon and glue go hand in hand, right? In artwork, ribbon and glue go hand in hand. So riboflavin deficiency is diagnosed by estimating RBC glutathione reductase activity. Right? What is it? It is RBC glutathione reductase activity for riboflavin. B6. There is a reason why I did not write the number 6. I've written the word 6, S-I-X. What is the last letter in 6? X. So whenever you suspect B6 deficiency, the last letter is X. That's the clue that is given to you, that you have to estimate xanthurenic acid. Okay. So whenever you suspect B6 deficiency, what should you estimate? You should estimate xanthurenic acid levels. Okay, X stands for xanthurenic acid, and that level has to be estimated after X, the alphabet is Y. So xanthurenic acid has to be estimated after tryptophan load. Okay, after tryptophan load. Folate deficiency, F for F. Whenever you suspect folate deficiency, what should you estimate? You should estimate FIGLU levels in urine. After what load? F and G are already over. So after what load? Histidine load. Right? After F and G, it is H. So FIGLU levels have to be estimated after histidine load. Whenever you suspect B12 deficiency, you should estimate methylmalonic acid levels. Did I tell you B12 coenzyme form is adenosyl B12 that is necessary for methylmalonyl CoA mutase. So when that enzyme is defective, methylmalonic acid level will be high. So whenever you suspect B12 deficiency, you should estimate methylmalonic acid level after overnight fasting. Do you understand this? After overnight fasting. So are you clear? That's it. So this completes all that you need to know about vitamin deficiency diagnostic tests. So for thiamine, it is RBC transketolase activity. For riboflavin, ribbon and glue, it is RBC glutathione reductase activity. B6, xanthurenic acid levels have to be estimated after tryptophan load. Folate, FIGLU levels after histidine load. B12 deficiency, methylmalonic acid level after overnight fasting. Okay, so that's about vitamin deficiency diagnostic tests. So look at this question and give me the answer. Thiamine deficiency, what is it? RBC transketolase activity. Glutathione reductase, what did I tell you? Glue, ribbon. Riboflavin deficiency. Xanthurenic acid, B6 deficiency. Methylmalonic acid is B12 deficiency. Okay. The form of vitamin A which is stored in liver is, this will be the last question for vitamins. Okay. The form of vitamin A which is stored in liver is, what is your answer? The alcohol form retinol. Okay. That is a form that is stored. So what are the three forms of vitamin A? The three forms of vitamin A include retinol, alcohol form, retinal, aldehyde form, and retinoic acid, acid form. Alcohol form is the form in which vitamin A is absorbed, it is transported and stored. Okay, alcohol form is the one that is absorbed, transported and stored. Aldehyde form, do you see in the name retina? Yeah, in the name you find retina. Retina is in the eye. So that's a clue that is given to you. Retinal is the form that is present in eye. When I say it's present in eye, it is present as rhodopsin. Yeah, it is present as rhodopsin. So what is rhodopsin? Rhodopsin, until stimulated by light, is levensis retinal in the center. Right? What is rhodopsin? Until stimulated by light, it is levensis retinal in the center that is surrounded by opsin. So that's about the aldehyde form retinal. Now, acid form, there are two retinoic acids, all trans retinoic acid and 13-cis retinoic acid. All trans retinoic acid helps in differentiation of cells. Yeah, it helps in differentiation of cells. 13-cis retinoic acid suppresses keratinization of epithelium. Okay, it suppresses keratinization of epithelium. That is about the forms of vitamin A. So what is the right answer here? The form in which it is stored in liver is the alcohol form retinol. Okay. Vitamin E is what type of antioxidant? This is truly an one-liner. I have nothing to explain here. Vitamin E is a lipid phase chain breaking antioxidant. Right? What is vitamin E? We all know it's an antioxidant, but in NEET PG 2019, they made it more complex by asking you which type of antioxidant is it. So what is your answer? Vitamin E is a lipid phase chain breaking antioxidant. So this is the last part, miscellaneous part. The first question here is tyrosinase. So this is about minerals. Yeah, let's learn a bit about minerals. Tyrosinase is dependent on what? What is answer, all of you? Tyrosinase is dependent on copper. Okay, that is why what happens in copper deficiency, tyrosinase is not active. So what is not formed? Melanin is not formed. When melanin is not formed, that causes depigmented hair. Do you understand this? That causes depigmented hair. Was this asked recently? They gave a history of a child presenting with depigmented hair, anemia, neutropenia. It is caused by the deficiency of which mineral? Your answer should be copper. Okay. So let's use this chance to learn about all enzymes which are dependent on these minerals. Okay. Let's start with copper. So tell me copper. What are the enzymes which are dependent on copper? Cytochrome AA3. Copper dependent enzyme includes cytochrome AA3, which is present in complex of electron transport chain. Okay. And then ceruloplasmin, superoxide dismutase, tyrosinase. Okay. So can you tell me what are the enzymes which are dependent on copper? The enzymes that are dependent on copper includes cytochrome AA3, ceruloplasmin. What is the role of ceruloplasmin? Ceruloplasmin is a ferrioxidase which converts ferrous to ferric. Then this ferric is transported as transferrin. So tell me what happens in copper deficiency. Whenever there is copper deficiency, there is no ceruloplasmin, no ferric form, no transferrin. When iron is not transported, that causes anemia, right? When superoxide dismutase does not act, neutrophils get damaged. That is my neutropenia. So what are the manifestations of copper deficiency? Copper deficiency presents with depigmented hair because tyrosinase does not work. Anemia because ceruloplasmin does not work. Neutropenia because superoxide dismutase does not work. Right? And along with that, lysyl oxidase is also dependent on copper. All of you, don't get confused here. Lysyl hydroxylase is dependent on vitamin C. Lysyl oxidase is dependent on copper. Both are related to collagen cross-linkage formation. That is why for collagen maturation, you need both vitamin C and copper. Okay, that's all about copper-dependent enzymes. Now, zinc. Zinc is necessary for carboxypeptidase. Okay, zinc is necessary for carboxypeptidase, carbonic anhydrase, It is necessary for alkaline phosphatase and alcohol dehydrogenase. Okay, zinc is necessary for carboxypeptidase, carbonic anhydrase, alkaline phosphatase, and alcohol dehydrogenase. Selenium, frequently asked, what are the selenium dependent enzymes? Selenium dependent enzymes include glutathione peroxidase. Did I tell you that riboflavin deficiency, that is by RBC glutathione reductase activity? Selenium dependent enzyme is glutathione peroxidase, thioredoxin reductase, and 5' deiodinase. So tell me, what are the selenium dependent enzymes? Anytime you're asked, you should be able to answer this. Selenium dependent enzymes include glutathione peroxidase, thioredoxin reductase, and 5' deiodinase. Okay. Molybdenum. Have you seen MCQs on molybdenum in various forms? Right? Till some time back, they used to ask you a one-liner. Which of the following enzymes is dependent on molybdenum? Your answer should be xanthine oxidase. Okay. But recently they asked you a case-based MCQ. A person presents with hypouricemia, low uric acid level. Which mineral is deficient? Molybdenum. Because xanthine oxidase converts xanthine to uric acid. So whenever there is molybdenum deficiency, xanthine oxidase does not work, causing low uric acid levels. Okay, very good. Magnesium, right? Magnesium we all know is necessary for kinases. Apart from kinases, it is also necessary for glucose-6 phosphatase. And it is necessary for DNA and RNA polymerases. Okay, DNA and RNA polymerases. So that's about the minerals and the enzymes that are dependent. I want you to remember just two minerals for sure. Selenium is necessary for glutathione reductase, thioredoxin reductase, and 5' deiodinase. Molybdenum is necessary for xanthine oxidase. Other minerals, I think you will be able to recollect to a great extent. I want you to remember copper is necessary for cytochrome AA3, ceruloplasmin, superoxide dismutase, tyrosinase, lysyl oxidase. Lysyl oxidase is copper dependent. Lysyl hydroxylase is vitamin C dependent. Okay. Iron is absorbed in. Most of the minerals, most of the micronutrients get absorbed in the upper small intestine. Okay. Exception is B12. B12 is absorbed in the terminal ileum. Do you understand this? B12 alone is absorbed in the terminal ileum. Otherwise, all other minerals get absorbed in the upper small, very good, upper small intestine, which is duodenum. True about competitive inhibition is, okay. So I've included this in miscellaneous category because I wanted to cover every topic. And I'm not going to get into the details or the concepts behind this. I'm going to only tell you what happens in the presence of all these inhibitions. I'm happy that already many of you have started answering it. Yes, in competitive inhibition, all that you need to know is there is a competition between the substrate and the inhibitor. Right? In competitive inhibition, there is a competition between the substrate and the inhibitor. So when you increase the substrate concentration, you can overcome the inhibition. If you can overcome the inhibition, the final Vmax will be normal. You are able to overcome the inhibition, so the final Vmax will remain normal. But to overcome the inhibition, you have to increase the substrate concentration. So Km will be high. What is Km? For those of you who don't remember this, Km is the substrate concentration at half maximal velocity. Do you understand this? Km is the substrate concentration at half maximal velocity. I said in competitive inhibition, substrate concentration has to be increased. So Km will be high. Are you clear? So in the presence of a competitive inhibitor, because you can overcome the inhibition, Vmax is normal and Km is high. Okay. It's a one-liner session. So I'm going to fill up all these one-liner facts in the table, right? So what happens in the presence of a competitive inhibitor? What happens in the presence of an uncompetitive inhibitor, mixed inhibitor, and non-competitive inhibitor? Just shortcuts for you to remember, okay? So competitive inhibition, you have overcome the inhibition. So Vmax is normal, but Km is high, okay? Uncompetitive inhibition, remember parallel line, parallel shift, uncompetitive, parallel line, parallel shift. You're not able to overcome the inhibition. So Vmax will be low. Not only Vmax is low, Km is also low. Okay, memorize it. Uncompetitive inhibition, both Vmax and Km are low. Just remember parallel shift. Okay, mixed inhibition. In mixed inhibition, both the values are altered in the wrong direction. What do I mean by wrong direction? For me to say that an enzyme is active, I should be able to say that the enzyme's Vmax is high and Km is low. Okay, for me to say that an enzyme is good, an enzyme is acting well, I should say that Vmax is high and Km is low. But in the presence of a mixed inhibitor, both the values are altered in the wrong direction. So Vmax is low and Km is high. Mixed inhibition, Vmax is low and Km is high. Okay. Non-competitive inhibition. Okay. Non-competitive inhibition is normal Km. Easy to remember, right? Just look at the name. Non-competitive inhibition, normal Km. So Km is normal and Vmax is low. Have you understood this? Km is normal and Vmax is low. So these are the facts that you have to remember about all these inhibitions. So competitive inhibition, Vmax is normal, Km is high. Uncompetitive, parallel shift, both are low. Mixed inhibition, Vmax is low, Km is high. Non-competitive inhibition, normal Km and Vmax is low. Okay, good. So another one-liner related to respiratory quotient, right? So respiratory quotient, this you must have learnt in physiology. Respiratory quotient of a person who's on a mixed balance diet is 0.8, right? What is respiratory quotient? Respiratory quotient is carbon dioxide exhaled per minute divided by oxygen inhaled per minute. You know that, right? What is respiratory quotient, all of you? Respiratory quotient is carbon dioxide exhaled per minute by oxygen inhaled per minute. Or in other words, for this much of oxygen that I inhale, how much of carbon dioxide is being produced by my body, right? And that is dependent on the fuel which a person consumes. Okay. If a person is on a carbohydrate rich diet, if a person is on a carbohydrate rich diet, respiratory quotient is 1. Okay. Now, if a person is on a protein rich diet, right? P, you reverse it. What is it? 9, right? P, you reverse it, it is 9. What is it? 0.9. Okay. For fat, it is 0.7, right? This is F, right? You inverse it, it is 0.7. So for fat, it is 0.7. And for a person who's on a mixed balance diet, it is 0.8. Got it? Have you memorized it? For carbohydrate, it is 1. For protein, you inverse it, it is 0.9. Invert it, it's 0.9. Fat, F, right? You invert it, it is 0.7. For mixed balance diet, it is 0.8. Inborn error of metabolism screening is done by, right? INI-CET may question. Screening of inborn error of metabolism is done by tandem mass spectrometry, whereas inborn error of metabolism is confirmed by enzymatic assay. Okay, screening is done by tandem mass spectrometry and is confirmed by enzymatic assay. Lead inhibits. Last topic for tonight. Okay, lead inhibits. It inhibits ALA dehydratase. Okay, So you need to know what are the enzymes of heme synthesis that are inhibited by lead. Lead inhibits ALA dehydratase. It inhibits coproporphyrinogen oxidase and it inhibits ferrochelatase. Okay, we have no other go but to memorize it. Tell me what are the enzymes which are inhibited by lead? ALA dehydratase, coproporphyrinogen oxidase, not one enzyme. It inhibits 3 enzymes of heme synthesis: ALA dehydratase, coproporphyrinogen oxidase, and ferrochelatase. Last question. Which of the following porphyrias presents with only neuropsychiatric manifestations? Okay, only neuropsychiatric manifestations. So porphyria patient either presents with neuropsychiatric manifestations wherein they present with acute abdominal pain because of aberrant pain, acute abdominal pain, and they present with cyclical bizarre behavior. That is one category. Or your porphyrias present with photosensitivity, wherein whenever they go out in sunlight, there is itching, blister formation, right? That is photosensitivity. Or porphyrias present with both. Okay. And only neuropsychiatric manifestations without photosensitivity is a classical feature of the most popular acute intermittent porphyria. Yeah, that's a feature of acute intermittent porphyria. So what is the right answer, all of you? The right answer is acute intermittent porphyria. A bit about other conditions. Congenital erythropoietic porphyria is the vampire disease. Okay, congenital erythropoietic porphyria is the vampire disease, wherein for fear of photosensitivity, they come out only during the night like a vampire. Okay, so that excessive photosensitivity they get exposed to. So the most severe of all photosensitivity porphyrias, congenital erythropoietic porphyria, which presents with only photosensitivity. Okay, variegate porphyria. Variegate is for various, meaning various manifestations. What do I mean by various manifestations? Both photosensitivity and neuropsychiatric manifestations. Okay. Hereditary coproporphyria. Co. What do you mean by co? Both, right? Both meaning both neuropsychiatric manifestations and photosensitivity. So tell me, what are the two porphyrias which present with both? The moment you hear the word both, remember co. Hereditary coproporphyria and variegate porphyria. Okay. So to summarize about porphyrias, what are the 3 categories of porphyrias, all of you? The first category presents with only neuropsychiatric manifestations. The second category presents with only photosensitivity. Third category presents with both neuropsychiatric manifestations and photosensitivity. Okay. What comes under the first category? Acute intermittent porphyria, the most popular, no photosensitivity at all. Not only acute intermittent porphyria, something which resembles that. What is it? ALA dehydratase defective porphyria. Okay, ALA dehydratase defective porphyria and acute intermittent porphyria present only with neuropsychiatric manifestations, no photosensitivity at all. What are the porphyrias which present with only photosensitivity? The most severe vampire disease. Which is the vampire disease I told you? Congenital erythropoietic porphyria. The most common. Which is the most common porphyria? Porphyria cutanea tarda. Cutanea, the name by itself tells you only skin manifestations, only photosensitivity. And then erythropoietic protoporphyria, the last one, erythropoietic protoporphyria. These 3 present with photosensitivity. Okay, both. What did I tell you for both? Both would include hereditary coproporphyria and variegate porphyria. Okay, hereditary coproporphyria and variegate porphyria present with both. Are you clear? So can you all repeat this from wherever you are? Neuropsychiatric manifestations is acute intermittent porphyria and ALA dehydratase defective porphyria. Photosensitivity is congenital erythropoietic porphyria, porphyria cutanea tarda, and erythropoietic protoporphyria. Both hereditary coproporphyria and variegate porphyria. Okay, so can you tell me the answer here? With only neuropsychiatric manifestation is acute intermittent porphyria. Okay, I hope you all enjoyed this session. Right, so we have covered the entire biochemistry. I covered clinical biochemistry, carbohydrates, lipids, proteins, genetics, vitamins, and miscellaneous topics. Okay, so I want you to go through the session again, memorize all facts as and when you watch the session, and I want you to revise it multiple times. There is a high probability that many questions are asked based on the session. Okay, so happy Pongal again, happy Makar Sankranti again. Thank you. Good night.